Events. Elevate your event with Ayedi TV. Are you looking for ways to make your events more memorable? Contact Ayedi TV for professional event live streaming on
for
Facebook.
Feeding us with breakfast. May we rise for the anthems.
Afrika Mashariki, tuwezeshe kuishi kwa amani, tutimize na malengo yetu. Jumuiya yetu sote tuilinde, tuajibike, tuimarike. Umoja wetu ni nguzo yetu, idumu jumuiya yetu.
Almighty and everlasting Father, we thank you for today. We thank you for the opportunity of gathering us here today. We commit this launch into your hands. It is you who has started it and you bring it to accomplishment. May you bless the organizers, bless the PI with wisdom, with peace that she needs, with a supportive network, that she will succeed. In Jesus' name, amen.
Thank you so much, Dr. Edith. Let's take our seats, ladies and gentlemen.
Ladies and gentlemen, we recognize the arrival of the Acting Commissioner, Reproductive and Child Health, Minister of Health, Uganda, and Angela. Go ahead, thank you.
The Vice Chancellor, Professor Celestine Oboa, your two deputies, Professor Nixon Kamkama and Deputy Vice Chancellor F&A, Professor Tushaboma Kazoba, our keynote speaker of the day, our collaborators, MAST staff, and invited guests. Good morning. We are here to see a project that has seen it all, and has made it to support mothers in their times of need. They may lose track, but Dr. Esther says they should not. She wants to see them succeed till the day they have a baby and the baby is healthy. What more can you give a nation than supporting a mother? Esther, thank you for the thoughtfulness and your team. I thought they were going to clap for you. Allow me to welcome and recognize our partners from MGH. Thank you for coming. Here we have Professor Jessica Heber. Say that again. Oh, I gave you a Ugandan name. You remember it? What is that one? Agaba. Yes, she gives us a lot of. Please welcome Professor Jessica Agaba. Because the name Heber was not so easy. So, yes, you got it well. Clap for her. Yes. And Professor Mark Sidner will get you a Ugandan name and a cow. So we shall do the baptism here. I also welcome the DH Mbarara, Dr. Peter Sebutinde. Thanks for being with us. Our partners from Epicenter, thank you for being with us. Global Health Collaborative, represented by Dr. Stevens Asimwe. Welcome back, doctor. Did you bring some chocolates? We have dentists here. Thank you for being with us. Ladies and gentlemen, let's put our hands together for the project director present here. And it's all about the project. Allow me to welcome and recognize Dr. Ester Cathylyn Atukunda. You're blessed and you're blessing others. Allow me to welcome and recognize the co-investigators. And these are our partners still again, Professor Jessica Agaba, Professor Mark Sidner, Dr. Mujenyi Godfrey. We do have in absentia Associate Professor Peter Waiswa from Makerere School of Public Health, Dr. Godfrey Mujenyi, a senior obstetrician and lecturer at Mbarara University of Science and Technology. We do have Mr. Eli Atuhumuza, who is a biostatistician on the project. Ladies and gentlemen, allow me to welcome and recognize our partners from University of Alabama at Birmingham, Dr. Lynn Matthews. Thank you for coming. And we also have Dr. Vance. This is sponsored by NIH. Ladies and gentlemen, at this moment, allow me to welcome the Vice Chancellor of Mbarara University of Science and Technology to welcome us and give his remarks as the Vice Chancellor, Professor Oboa. That hand clap is not enough for the congratulation. I still want my job. Ladies and gentlemen, the other co-investigator is Professor Celestino Oboa. Please clap hard, I still need my job. Apologies.
Thank you, Piero. Good morning, ladies and gentlemen. Unfortunately, there's need for this very long protocol of recognition, but I'll cut it short and recognize people in batches. But allow me to recognize the PI of the Support Moms Project, Dr. Ester Atukunda, and your co-investigators. I recognize the dignitaries who are here, my deputies, Professor Nixon and Charles, other university leadership, deans, directors, lecturers in various positions. I also recognize our colleagues who've traveled across the Atlantic to be here today, Jessica and Mark. Thank you very much for coming back home. And you were promised a cow. I hope it is not the Kinyankole promise of a cow which never gets to be true. I hope this time the one who was promised the cow will indeed deliver the cow. The Acting Commissioner for Reproductive Health from the Ministry of Health, thank you very much for making this difficult trip from Kampala and coming here. And your colleague, I was told Dr. who? Jack? Dan, yes, also from the Ministry of Health. And everybody who is here, you're all very important. And so if I do not mention you by name, don't take offense. I recognize everybody. It's a rainy morning, and there is something strange about rain in Uganda. Every time it rains, everything comes to a standstill. But it is something we need to learn to cope with. Otherwise, productivity will get to zero because we are afraid of rain. We need the rain, and we are afraid of rain. So let's hope that rain is not the excuse for us to start proceedings late all the time. We know why we are here this morning. Dr. Mujenyi was educating us how to scan the QRC, what did you call that? QRC code? Yes, to educate us what this launch is about. So when you have, is it called Kakibiriti phone like my type? The one which cannot scan? You can talk into it and ask Google to tell you what the QR code is and what it's going to show you. But I want to say this. Support Moms project is one of those projects that have a key, or should be having at the end of it all, a key impact in Uganda and probably the whole of Africa. First of all, many of us may not know what RO1 projects mean, or the RO1 funding opportunities by the National Institutes of Health. I will leave that for Dr. Atukunda to educate us what an RO1 project is. But in brief, it is an opportunity for the researchers who have proposed a mechanism to test in the community of improving the health of pregnant mothers. It's going to be tried and tested, and the results hopefully should lead to some policy impact, which when you look at the partners, where I'm standing here, you have the Ministry of Health, representing the government of Uganda, University of Alabama, Massachusetts General Hospital, Harvard University, and the NIH. Of course, Mbarara University should be somewhere up front there. And the community, because we are going to work together with the community. When we have successfully tested the ideas of improving health of pregnant mothers, we should be able to communicate to the policymakers that we have tested and tried this intervention and it has worked, and we are recommending it for adoption by the Ministry of Health. When it is done, it means that now the whole of Uganda will be able to apply that. The future and the very purpose of this project is that the future and health of a nation begins with the health of the pregnant woman and that of the fetus she's carrying. After she's carried this fetus for a certain number of months, I don't know in human beings, but I know in elephants it's 2 years. You could ask your neighbor, how many months does a human being carry pregnancy? At the end, we expect a successful delivery of a healthy baby. We also expect that the mother remains healthy after the delivery. So the whole purpose of what this project is endeavoring to do is to ensure successful carrying and completion of a pregnancy. As you may note, one of the health indices which Uganda is not very proud of is the maternal mortality rate and the neonatal as well as infant mortality rates. I would say we are not very proud of those indices. But those are areas that we expect to improve. And it is not for one person. It is an opportunity for all of us seated here to see how we can contribute towards improvement of those indices. Those indices contribute to other health indicators. And some of the health indicators, which there are several, but I could list a few. For example, access to health. And Support Moms is in a way trying to see how we can improve on access to health for the pregnant woman. Of course, the other health indicators are things like reproductive and sexual health. There could be a dentist here, oral health, mental health, and I'm sure there are clinicians here who are psychiatrists. There are people who are concerned with the environment. And today, one of those indicators is you find it is being flashed. What is the environment, the purity of the environment, the air around, quality of air that we breathe, and so on. Water. What is the type of water that we have access to? Surface water? Is it clean water? Is it underground water? Is it water that has been purified, treated, or we are relying on the age-old well, and we are not too sure where this well, the water is coming from. And so you have pockets of diseases because of issues to do with poor environmental health or quality of the environment we are residing in. So access to health is not only for you to be able to walk to the nearest health center. That is important. And everybody here should be able to walk to the nearest health center whenever you feel unwell. But there should be a mechanism of ensuring that you make the health at home. And in the project, we are trying to ensure that the mother makes the health at home and be able to access the health facility as and when she's required to do so. So making health at home, meaning she is supposed to be able to be reminded for certain things. So this project is we are talking about making use of technologies that we have access to today. And each one of us today has that technology in our hands or in our pocket. And we have used it for other things except for ensuring our health. We have used it for calling you, for those of us who, this is not for Jessica to hear. So Jessica, you can hear with your ears closed. In the typical African home, I am seated outside the kitchen, but I take the phone to call my wife who is inside the kitchen and ask her, how long are you taking preparing that food? Can you bring the food now? Using the mobile phone. Meaning, we have a technology, but we are using it for trivial things. We are using these technologies for trivial things. But with this proposal, with this grant, we are trying to make use of the technologies that we carry in our hands to improve health. So when you talk of M-Health, it is referring to mobile health. And we have mobile technologies that we are using today. The phone is indeed a tool that can be used for different aspects of health. And this is an opportunity for us to go into. So the details of this is going to be presented by Dr. Atukunda and the other speakers. My colleagues, Mark and Jessica, are also going to give their perspectives of this grant. But I can assure you that this is one of the best well-conceived proposals that has ever gone through the NIH approval system. You may, when you access that code, it will take you through the scores that it got. To get a score of 10 and to be, is it the 1 percentile? 1. It means you've got nearly 100% score. Some of us get when we have about 20, 25, and so on. Even when you've got 30%, you've done very well in the NIH system. But to get 10, you are in another league. So congratulations, Dr. Atukunda, with your team. Indeed, I couldn't have been prouder as the Vice Chancellor of this university. I was a leader in Makerere, and we got grants in Makerere, and we never got a grant that had a score of 10 or a percentile of 1. And recently, I've met people who are saying, Mbarara, you are now giving Makerere a run for their money. Indeed, Mbarara University, be proud of yourselves. You are indeed now a force to be reckoned with in Uganda and if not, within Africa. In the recent meeting we had in Rwanda, in the DSI Africa, somebody presented statistics of grants funded by NIH in Africa. Do you want to hear the good news? In the whole of Africa, South Africa leads in the total number of grants and the total amount of money awarded from the NIH. Who do you think is second to South Africa? Uganda. Uganda gets almost as much as South Africa gets, with a little difference. And within Uganda, other than our old brother Makerere, Mbarara is next in the number of grants that are won. And that's why I'm saying I'm very proud today to be standing talking about a grant awarded by the NIH to Mbarara University of Science and Technology. For you, the people who have been dreaming about writing and winning a grant, now you know it is possible. Go back, sit down, burn the midnight. These days you don't use candles. What is it that you use? Kerosene? Oh, solar. Burn the midnight solar so that we get the next 3 or 4 R01s to Mbarara University of Science and Technology. I will happily go to my grave. Ladies and gentlemen, I thank you so much for coming this morning and welcome you once again to this launch. And I'm very sure that if you have missed coming here today, you have missed something great. We welcome you on behalf of the research team and on behalf of Dr. Atukunda for this wonderful achievement. The sky doesn't exist for you, okay? And space is ever expanding, therefore we do not know where the sky is anyway. And so you have all the capacity to do what you can do for this country and for yourself. And thank you very much for this achievement.
Please put your hands together for the Vice Chancellor. And let's put our hands together for the organizers, and I'll tell you why. They made sure that coming up here, you have to be sober, you don't have to fall down. So they're testing who took some wine last night, and the Vice Chancellor and me are not yet. Let's see the next speakers. So, thank you, our dear organizers. It's really, yeah. Allow me to invite my co-MC to recognize some people present, but as he comes, allow me to welcome and recognize the DHO Mitoma District. DHO Mitoma District. I think he has stepped out, sorry. Then CHO, Mbarara City. He has stepped out also. Are they making a call about an outbreak? And then we have VHTs in the house. Dr. Esther, thank you for considering VHTs. Please stand up if you're a VHT. Yes.
Yes.
Without you, we cannot disseminate the information to the community. Thank you for coming. Welcome and recognize the academic registrar, Dr. Martha Choshaba. Yes. Let's welcome and recognize the Mastrek. And the chairperson is here, Associate Professor Alele. He's camera shy, but today he has, stand up straight, yeah. He's here with his team, Gladys Nakalema, Dixon, and Kate. Mastrek, please stand up, and Esther herself. Thank you, Mastrek, for being here, and thank you for always approving our researches in and on time. Dr. Godfrey?
Yes, thank you, Angela. I wish to continue recognizing everyone. And in a special way, I wish to recognize the presence of Dr. Esther's parents. Mr. and Mrs. Kamuntu, stand up for recognition. I wish to recognize the project staff. I know you're outside, but enter Eunice and the team. The project staff, Josephine, Mendra, wherever you are, Sam.
Please come here.
Come here because people need to know who you are. Kachiro, you also need to come here. We want to be sure that everybody knows that we are part of MAST and not anywhere. Kachiro, the HR MAST Grants Office. The coordinators for Mbarara District, Mbarara City, and Mitoma District. I wanted Kachiro to come here so that you also call the 4 recently hired staffs. I know they are here and you know them. Those people you called, they know themselves. The 4 people come over. The 4 research assistants. I don't know you yet because you're still brides.
Like you did the interview and passed it.
You're already here.
Yeah.
Some
Yes.
of them are already in here. As I see Joan coming. Are you one of them? So, of course, I don't want to call Dr. Esther here, but I want you to know that we have a big team that is going to steer this forward. Give them a big hand appraiser, and then they can go and take their seat. I wish to recognize the presence of the director of the ISS clinic, Dr. Moindike Winnie. Thank you for being with us. And I think, Angela, you're continuing with the recognitions.
Yes,
before
in the house we have Professor Judith Hahn from University of California, San Francisco. So, ladies and gentlemen, in the house we have Harvard, California, Mbarara, MAST, yes. We have Birmingham. We have even the University of Understanding is here. And that one is known by a few people. You never go there if you don't want. The academic registrar is Inspector General of Police. So, welcome to this project once again. And at this moment, allow me invite my co-MC to come. And you know, in the Bible, they say, I'm not even worth to unstrap the sandals of their shoes. In your capacity as a senior lecturer, please introduce to us the next speakers. Finally, you've come up.
Thank you. I didn't take some wine, but I'm not sure whether I want to take some today. I wish to continue recognizing the healthcare providers. If you have ever provided healthcare as a midwife, as a nurse, as a doctor, as a professor, a teacher, please stand up for recognition. The healthcare providers, even the commissioner himself. Yes. Good, great, thank you. So these are the people who are responsible for our health, and we want to recognize their presence. Allow me to, in a special way, invite, in no particular order, they know themselves, Dr. Mark Sidner, who is a long-time research collaborator, and particularly Dr. Ester's PhD mentor, the one that really made Ester shine to come here and share his comments with her. Thank you. You're welcome.
Thank you, MCs, colleagues from the Department of Health, from the university, from across the globe who are here today to celebrate this day together. I will be brief. I was given an hour, but I'll try my best not to take the whole thing. I'd actually like to spend the next few minutes telling a little bit of a story. The story starts in the year 2011. It's hard to remember back that far. At that time, Barack Obama was president of my country. This hotel did not exist. I don't think the country of South Sudan existed yet. It was a ways back. And Mbarara, I don't think, had officially been declared a city yet by the country of Uganda. So some would say it wasn't yet on the map. And I can tell you one thing, from a research perspective, it was not on the map. When I arrived here in 2011, there was one of these R01 grants, which I'll talk about in a minute, and it was held by an American, someone named David Bangsberg, so many of you may have heard his name before. But he was quite an esteemed professor from Harvard, and he was the only person who held a grant, an R01 grant here in Mbarara. So what is an R01 grant? I'll discuss these grants almost like a metaphor. So when most researchers get started, they start on a small grant, something called a training grant. And you can think of these a little bit like the foothills of Mbarara, right? So who here knows people who've climbed the foothills of Mbarara? I often do it with our friend Professor Stephen, but they're not so tall, right? They're a little challenging, but most people can get up those little foothills, right? And these are training grants. The next step, I would say, is something like what we call the Mountains of the Moon, or the Rwenzori's, right? These are pretty challenging. So maybe we know a few people who've climbed these mountains, these things called the Mountains of the Moon, Rwenzori's, but not too many people have made it that high. Okay, those are things that we'd call a mentoring career grant, or a K grant. The last stage is something you hear about. Past the Mountains of the Moon, maybe the Mountains of the Stars, these are these R grants. Metaphorically, that would be a little bit like climbing Mount Everest. We know a few people who've done it, but especially in places like this, it's essentially unheard of. So it's 2011, and a young woman walks into my office, and she says, I hear that you're a scientist. And I'm like, not quite. I was just a fellow myself. I was on the foothills of Mbarara at the time. And she says to me, I'm working on a project. And I said, great, I love projects. Tell me more about it. And she begins to describe to me a project who someone as a PhD student has done, which is a randomized control trial, one of the most important and effective forms of science, to test a medicine to try to prevent bleeding in women at the time of childbirth. And the first thing I could ask myself was, why is this woman asking me for help? It should be the opposite. I should be asking her for help. She was so far advanced in her scientific career that I was honestly wondering if I had anything to offer her. But she told me about her issues. She had some issues with some study design. We sat together. We worked on them together. And before you knew it, she finished this enormous study of 1,000 women giving birth to show how to best protect women giving birth. Next thing you know, she's being invited by the World Health Organization as an expert in this area. She's climbed those foothills of Mbarara, and she says to me, I'm ready for the next stage. I'm ready for the Rwenzori's. And no one here had ever done that before. No one at MUST had ever done that before. But if anyone could do it, it was her, and she had a colleague at the time, Angela Musimeta, who was also in the same stage, and they climbed that mountain together. And we sat back and we said, wow, frankly, I didn't know it was possible, and you've made us all so proud. But she didn't stop there. This K grant, these middle stage grants, they're extremely complex. She did numerous studies to develop an application for women who are pregnant to try to enhance their ability to get to clinic, to have antenatal care, and to safely deliver babies. And it was just an idea at the time, and frankly, it did seem a little bit crazy that someone here would develop something so thoroughly, so effectively, and test it. And she showed in a small pilot study that it worked. And we were celebrating, and she published, and she published, and she published. And then she said, I'm ready for the next stage. At this point, I have to be totally honest, I was not so sure if she was going to climb Everest, because no one had climbed Everest. There had never been a person at Mbarara University of Science and Technology who had ever climbed Everest. There were a couple in Uganda at Makerere, but there had never been someone here who had done it. She wasn't willing to quit. She brought together a team of people you've heard about today. She took her preliminary data from the top of the Rwenzori Mountains, and she put together a grant that I can tell you, as the Vice Chancellor just told us, is the only grant I've ever been involved in my life. As an investigator, as a co-investigator, they got a perfect score at the NIH. So Esther, all I can say to you is, you climbed Everest. You're the only scientist from this university who's ever done it. You're a woman scientist from a low-resource country in Africa. I'm not even sure if you can see us anymore from the top of that mountain. But we see you. We are so proud of you. And as the Vice Chancellor said, you have, believe it or not, like it or not, immediately become a source of inspiration, a role model to an entire generation of scientists who now can say, you know what? This is possible. Thank you for everything you've done for this community. Thank you for letting us be part of your team, and we cannot wait to do this together.
Check your wine test, please. Well, thank you, Dr. Mark Sidner. That was impressive. In no wastage of time, I will call Dr. Jessica Agaba, Professor. Dr. Jessica is a professor at the University of Harvard and Mass General Hospital, and she is one of our longest serving collaborators at MUST. She is also the Director, Global Health at the University of Harvard. You are welcome. Thank you for mentoring me along the way. Thank you.
So good morning, everyone. And thank you so much to everybody who's organized this incredible event. I mean, just looking out at this audience, Esther, stand up and look. I want you to see. Look at all these people who are here to celebrate you and to celebrate the team and the work that you've done. So I think Mark did an excellent job of explaining what an R01 means. You know, this is a 5-year grant. It's a lot of money to do a very large project. And just to add a little bit more to what it really means to have an R01, it's kind of the international symbol that you are an independent investigator. It means you've arrived. There's a lot of work to be done, but it really is a moment. It's a distinction in anybody's career development. So congratulations, Esther, for reaching that moment. And what I'd like to take a few minutes to do is to reflect on what it really means to get where you are. We've heard about the hills, the Ruwenzoris, Mount Everest, but Esther and I were actually chatting the other day about career development. And I think many of you who know me know that I spend a lot of time thinking about how to help people develop in their careers, how to find their passions, how to work within the environments where they are, how to find collaborators, how to build and grow. But I can only do that from my perspective. You know, I am an American woman. I can tell you what it was like for me. I had one of those career grants that Mark talked about. I wouldn't be here today if it weren't for David Bangsberg and for countless other people who helped me develop, who helped me find what my skills were, helped me develop new skills, and then to apply for these grants to do whatever it takes to develop as a scientist and a clinician. But that's my perspective. And as much as I try, and I do try, to understand how to adapt that to anybody I'm speaking to, it's not my experience. So I bring my biases, I bring, you know, whatever is behind me with me. But I think what Esther can do, and what many others of you in the room, this is Esther's moment, so I want to focus on her, but I know there are lots of successful people in this room who can share that journey to those who are also here in this room or want to be in this room. From your perspective, you can talk about what is it like to make that first step? What was it like to go approach Mark 12 years ago? It's really hard sometimes. There are lots of inequities, especially in global health. There are lots of inequities even within a given culture, a given setting. We'll be talking about that actually tomorrow in a mentoring workshop. So how do you make that first step? And then how do you make that second step? How do you develop that project? How do you make it through to completion? And then how do you rebound when you have a down moment? You know, all of us have struggled with grants that aren't funded, papers that are not published right away. How do you overcome that? And I think by working with role models within your community, I think it's easier. I think it's more clear. So I'm always happy to talk about career development and always happy to think through these issues with anyone. But I'm so glad to welcome Esther into the fold so that she can help guide people who are coming from the exact same circumstance that she is. So thank you, Esther. I've already promised you in front of all these people to help with career development, but it's such an incredible role. And I think as Mark said, our successes as mentors are really the successes of our mentees. So I'm going to thank you in advance for all the successes you're going to help here at MUST. And those of you, again, who know me, know I talk a lot about the village. So the village, everybody knows the expression. It takes a village to raise a child. It takes a village to create a successful researcher. And we are Esther's village. We are her colleagues, her mentors, her supporters. And I think it's really important within the village to think about that community and to think about what we can do as a village together. And we had a really nice symposium yesterday from the Global Health Collaborative where we talked about the connection of research to the community. And we had wonderful representatives from our community advisory board. We talked about how to connect with communities. And one of the principles that we talk about in this research village is how to promote locally grown solutions. And those connections come from being in the community and from working together in a village like Ubuntu philosophy of what can we do together? How do we help those who we are with? How do we help each other? And I think this project, Esther will tell you more about the specifics, but it is a homegrown solution. And those homegrown solutions are all too rare. Too often it's people like me who come with solutions, and I think they're informed, I think they're good, but the solutions that are most likely to work and to be sustainable and to have the impact that I know we all want, those are the homegrown solutions. Those are the ones that really come from all of you, from the community, from those of you who've thought about this, who've lived through this, who've delivered babies or dealt with the complications in the hospital. And this is just such a wonderful example, not only of the career development and that role model that Esther can play, but also this concept of the locally developed homegrown solution that has gone from an idea here in Mbarara all the way through to funding from the NIH, the world's largest funder of biomedical research. So I encourage all of you to pay attention, I know you are, but to pay attention to what you see around you. Find those innovations, find those sustainable solutions that we can then support you as a village to develop into these internationally funded and ultimately recognized awards. So thank you, Esther, for this incredible example in so many ways of what I hope many of you will be able to do over the years. And working in global health, I often ask myself, why are we working together? Why am I here in Mbarara? I mean, I love Mbarara, so I keep coming back. This is my 15th year. But I always have to think, what am I bringing to the table? Who am I working with? Why am I working with them? How are we working together? And I've sort of redefined global health for myself to make sure that I always know the answer. And for me, I think of global health as collaborative efforts to optimally promote health according to these locally driven priorities and values. And that is absolutely what we're doing here today with Support Moms. So thank you, Esther. I look forward to hearing more from you and from the other speakers today. But let's give a round of applause for this project and for Esther. Thank you.
You passed the test. Thank you.
Thank you, Professor Agaba. We have a Professor Agaba in pharmacology. So greetings to him that he has another colleague called Professor Agaba. Yeah. And then the reason you are given that name, you remember? Agaba. Because you donate, you give, you like, you look around and find the right solution. So thank you so much, Professor Jessica. And in no time before now, we'll get Professor Mark a name. Ladies and gentlemen, in the house, we do have other people present. Allow me to welcome and recognize the grants office team that is here with us. Please stand up for recognition. Must grants, ladies and gentlemen, those are the people handling all grants that come in, and one thing they're well known about is they're strict when it comes to money. Thank you for being stingy, but it helps us as a university for accountability. You do us so great. Ladies and gentlemen, allow me to welcome and recognize, still in the top administration of the university, we do have Basa, the university Basa, Mr. Felix Majezi, CPA Majezi Felix. He came with the auditor, internal auditors. We have Mr. Mutebi Godfrey. Please stand up. We have Bridget Nansubga. Yes. We have Lois. Lois, please stand up. Oh, your other name here? Yes, thank you, Lois. Yes. We're talking about mothers, support moms. Ladies and gentlemen, in the house, we have the obstetricians in the house. Please stand up for recognition. Dr. Mjenyi, you're allowed to stay seated. There are some that I want to stand up. Yes. Others? We have midwives. Those ones, midwives. Push, yayanga, tandama. Those are the people. Yes, without them, the world will be empty. Now, of recent, ladies and gentlemen, research has shown that mental cases in Uganda have gone high, and one person has chosen to take care of pregnancy, psychiatric, whatever. Please, allow me to welcome and recognize Dr. Kathy from the nursing department. She did her PhD in relation to maternal mother health, mental health of mothers. So she doesn't work alone. Allow me to welcome and recognize the psychiatric department of Mbarara University of Science and Technology. Dr. Rukundo Dr. Sikolastika, and potential patients in the house. Welcome. We are all potential patients. No problem about that. Dr. Godfrey. Dr. Godfrey, the next speaker, please. He's also a high-profile person. Yes, Dr. Godfrey tells me that we've been seated for long, and he likes the fishes of men thing. Can we try it one more time? Yeah? Can we try the fishes of men one more time? Yes, it's the usual one. I, female is F, and male is? So I is everybody. So I, we all stand up. Make, M, now you see professors are already up. They don't waste time. The word that has aim is where the male stand up, and the word with F, the female stand up. I like teaching professors. So when you teach a professor, who are you? Angela, you're blessed. So I will, okay, everybody, I will make the men stand up. Make you fishers are women, fishers of men. Fishers, the cameraman is in all. Fishers, the male, you sit on F. Fishers of men, if you follow me. So we take it faster. I will make you fishers of men, fishers of men, fishers of men. I will make you fishers of men if you follow me. And the ladies won! Yay!
Thank you. Thank you. I would like to use this opportunity to recognize the audience who are online. We do not take you for granted. There is an official YouTube channel broadcasting this event live, and we recognize your presence and being with us. When this grant came about, people started coming to our home to look and partake on this money. It is my humble communication to all of you that that money is not in Nyamitanga, it is in Must. The money, if you want it, the university bursar is here, the university secretary. Don't come to Dr. Ester to look for jobs. Jobs are with the Kachiro Stand Up for Recognition, the Human Resource Manager of Grants Office. The dollars are not at home. Don't look for it from there. In that vein, I would love to recognize the people who have worked along with Esther as she grew up. Of course, I recognized the parents, and I wish to recognize the husband of Dr. Esther. Ladies and gentlemen, that's very important. Because whenever the husband comes back from work late in the night and is complaining about another maternal death, Dr. Esther doesn't sleep that night. But like a week later, she wakes you up in the night and asks you, Mbose, Dr. Mugai said the maternal mortality has reduced to what? I said from 336 to 189 per 100,000 live births.
That's good news. But how does a common person interpret it? What message do we give to a VHT to tell the person in the community about this improvement? And I told her, the easiest way to look at it is telling them that in the financial year of 2022 to 2023, 1,276 women were lost. In that year, when the budget for the country was 45 trillion Ugandan shillings, we still lost 1,276 women. I think that is the interpretation. It is not Uhuru yet. A lot still needs to be done. And that is the reason as to why this grant comes in handy. I wanted to recognize the people who have really shaped the dreams of Dr. Ester, and that is other than Father Bash Foundation. Whereas Esther walked into Dr. Mark Sidner's office, there are people whom Dr. Esther had bumped into that walked and created Mbarara's village around her, and they enabled her to move until that time when she walked into her, Mark Sidner's office. Father Bashobora, Reverend Father Bashobora, John Baptist, and the team, entire team, and Father Bash Foundation, you're welcome. I will ask all of you, if you're here, to stand up. Divine Mercy Hospital, all of you stand up for recognition. And stay standing, stay standing. There are tens of thousands of people who receive the honor of being helped along the way by Father Bashobora, myself inclusive, because you see I'm standing, to walk the journey with Esther to reach this village that we are celebrating today. Please extend our sincere greetings to Reverend Father Bashobora and the entire team. This function is live on AID TV. One of you will take the link to him and he watches it even after today. I thank you and take your seats. Allow me to take this singular honor to introduce our keynote speaker, Acting Commissioner. Very soon we want the acting thing to go away so that you become the full commissioner for reproductive health. And I know that's a top honor, but that's not the end. Dr. Richard Mugahi is a medical doctor with a specialization in public health. He works at the Ministry of Health as Acting Commissioner for Reproductive and Child Health. Richard has vast experience and that has gathered through working at different levels of the health sector in Uganda for more than 20 years. Dr. Mbarara, get his contact very nicely, because the next time you need a letter of support, you'll get it in half no time. Dr. Richard started his career as a clinician directly involved in patient care, and he rose to the rank of district health officer in one of the districts in Western Uganda, a position he held for years, and he has continued to be motivated by the fact that he needed to achieve 100% skilled birth attendant in the district which he led, and this he achieved with a 50% reduction in maternal mortality rate of that district. Dr. Richard is an award winner with Rotary International Paul Harris Fellow and many other awards, like I will not outline and finish. In COVID, when everybody was locked down, the health workers in Uganda were not actually locked down. We had our regular meetings on Zoom, and these meetings have continued. We meet every week, almost every day, with subcommittees. We review all maternal deaths that occur in this country. And Dr. Mbarara, we have created, and this is for learning experience, a community of practice for healthcare providers in Uganda. There's a time when we get meetings, and the meeting is having over 1,000 people, all keenly interested from the leave alone these things of being late. Time check is 7:30 every Thursday in the morning. We thank you, and I don't want to take a lot of time other than introducing you as an alumnus of Makerere University and the University of Melbourne in USA, and he's a fellow of Australia, Melbourne, Australia. He's also a fellow of the epidemiology in the US International Visitors Fellowship in combating infectious diseases epidemics. He has co-authored publications on respectful maternity care and maternal and quality of the newborn care. Ladies and gentlemen, I have to talk very nicely on Mugahi because he is my boss. He's a co-chair of the national and founder, the brain behind the National Safe Motherhood Experts Committee, of which I co-chair Safe Birth Subcommittee, and Dr. Dan Mbarara, Stand Up for Recognition, is another brain behind the successes behind the Ministry of Health, Reproductive Health Division. And the two of them, when we contacted them, they told me, Doctor, relax. We shall come to Mbarara and support Dr. Ester. We welcome all of you, and I will take this opportunity to welcome you to the podium with a round of applause to come and take up this opportunity as I set up your presentation. Thank you.
Thank you, Dr. Mugenyi, my very good old friend. I will stand on the protocol. It's been a complicated protocol this morning, but allow me, in a special way, recognize our host, Cathylyn, Dr. Cathylyn. Thank you so much for hosting us this morning. I've been ably introduced. I will not add anything. But I must say I'm extremely passionate about safe motherhood. I'm extremely passionate about maternal and child health. And allow me bring you greetings from the Ministry of Health. Dr. Dan Mbarara, we traveled together this morning. He bypassed me. I was on the roadside moderating another meeting at 7:30 somewhere, I think in Lukaya. I think today is a special day, like all the previous speakers have mentioned. And I actually consider this a great honor from the team, Mbarara and Esther, to make me your keynote speaker today. I tried to tailor my message around the topic of the day. Around the topic of the day. And as we move, I think this doesn't mean that I'm the most informed person about the topic, but I'm really privileged that I'm here to discuss something that I'm so passionate about. I want to thank the DHOs who are here, because they are our frontliners at service delivery points. The midwives have already been recognized. And the VHTs, though I'm not so sure if our VHTs will be picking us firsthand. But either way, you're welcome. Mwebale kwija. I was also born here, I think 4 decades ago, and I'm really happy to be back home. Now, for our message today, I want to really highlight what we are launching, the integration of patient-centered care, interventions into routine and natal care to improve maternal health in Uganda. The project Support Moms. Importantly for me is the key messages that come out here, the key messages that we are bringing out. We can look at this through, first of all, what Uganda's journey has been to where we are today. Dr. Mujenyi talked slightly about our indicators and how we are faring. I must say we still lose, as we shall see through our graphical presentations. But this has been our journey in terms of changing things around, trying to tweak some things around and achieve the best possible outcomes. And we are still tweaking. We are not finished. Perhaps this year we started something else outside this. We started a QI collaborative, a quality improvement collaborative, which I actually learned from Mbarara. The first time I visited Professor, the head of Dean of Medicine is a gentleman from Ngonzi. There's like a side room, there's like a small room for high-risk pregnancies in Mbarara somewhere there, and a very hard-working midwife in there. So when I saw what was being done in there and early identification of high-risk pregnancies, I realized that it was very imperative that we would actually modify our antenatal care and identify these risks early enough. So we have, I would say this is metamorphosis. So in 2016, that the WHO launched the revised ANC model to promote positive pregnancy experience. Uganda came on board in 2021, and we expanded our then goal-oriented and natal care protocols to include the WHO recommendations of 8 contacts and ultrasonography. And we had this as our new ANC model. So down there is that chart that shows the number of contacts that a mother should have and the packages in there. We've been able to conduct in 2012 the trainings to roll out the new ANC model. But what is important from this slide is in the scientific world, everything is dynamic as more evidence comes on board, and it links very well with what Cathylyn is going to do. Cathylyn is going to try out an intervention that generates new evidence, that this evidence and that demonstrates the clear interplay between academia, policy, and practice. My background, as I mentioned, right now I'm at policy level, so we rely so much on academia, what comes out as evidence from the academia to improve policy, and policy ultimately improves the practice or translates into practice. So I think that is what is key from that slide. I asked myself a rhetoric question: what does the ANC model aim to achieve? The new ANC model, importantly, it emphasizes to having more focus on achieving a particular aim. And the aim here was improve maternal and perinatal health, improve the health and survival of infants, increase this rate of skilled birth attendance. And at some point, I will try to navigate us through whether we've been able to achieve this. Then there's this last point is also to provide an opportunity or an entry point for other health programs like malaria, HIV, TB, and nutrition. This also leads me to ask another rhetorical question. Why is it important to address ANC and why now? We have realized, and you'll see through these graphical illustrations, yes, as I earlier mentioned, Uganda has been making progress, as you can see, from 2016 to 2022, and that's perhaps one of the sharpest drops in maternal mortality in an era that was crowded with the pandemic and epidemic. We had the pandemic of COVID and an epidemic of Ebola in Uganda, but we managed to achieve a 44% drop in maternal mortality. And I need applaud you, and probably we clap for ourselves because we've all been part of this achievement. It's still too far away from us achieving our SDG target by 2030. That's 70 or less than 70 per 100,000 live birth. We need more than ever before to leverage on the platform of ANC, antenatal care. And I'll be explaining at some other slides that is it just antenatal care or we need to look at both the coverage and the quality. And that's an interesting discussion. Are we only talking about coverage? Are we talking about experience of ANC? Are we talking about the quality of the ANC? So on this slide, if you look critically at the last graphs, I like narrative, qualitative and quantitative. So beautiful graphs showing on the far left, you can see our UDH demographic health surveys where we started from 2001 as low as 40. I was comparing antenatal 4, antenatal visit 4 plus and institutional deliveries. Remember from my previous page, I did mention that one of the targets for this reorientation into the new antenatal care model was to see if we can have an increase in skilled birth attendance. So you can see the dark blue is our skilled birth attendance that has progressively moved from 37 to 42, 57, 73, and currently 91. Again, our birth attendants, the skilled birth attendants in the house, a big round of applause. Skilled birth attendants, obstetricians, midwives, you're all in there. So we look at that middle graph. It's illustrating ANC by skilled service provider. You can see again, we've been making progress, and the current one is the 95. A slight drop, but that's still okay. And then you also see we have, this should be the institutional, no, the far left right is summarizing what we already have on this combined graph. I again ask myself, what were the key areas of focus, and have we been able to achieve this? Because this will form the basis of my simple analysis as a programmer. If our areas of analysis, how are we doing in our areas of focus? Importantly, ANC, quality antenatal care, presents us with an opportunity, first of all, to interface with our pregnant mothers. It's very important that the healthcare system interfaces with the pregnant mothers. Because as you have seen the trends, At one point, they were not appearing. We are not seeing them anywhere. We didn't know where they were. We didn't know who was pregnant. We didn't know who was delivering where. But over the years, we've seen that story changing, mothers coming to our healthcare system. We need to maintain that. We need to look at what are the facilitators for them to come. We need to amplify them. We need to continue engaging them. We need to manage their expectations. We need also to measure experience of care. There are very, very few systems in Uganda that measure experience of care. And until you measure experience of care, then you're not providing care. So client satisfaction surveys and many other academic measures that can really measure experience of care. So number 2 is the therapeutic interventions that were part of our areas of focus because we are having so many mortalities and morbidities for both the mothers and the newborns, resulting from infections that could be identified and treated. Also the focus on education and planning for safe birth, emergencies during pregnancy, preparedness for emergencies, readiness and preparedness was also very critical and was our area of focus. We also need to look at ANC as an opportunity to address the big killers of our mothers. I picked this slide to enumerate what the big killers of our mothers are. As you can see, red represents danger, but also here it represents blood. Hemorrhage, obstetric hemorrhage represents the number one, has been actually for the last 20 years, the number one killer of mothers in this country. We are not sleeping. We want to tackle this head on. And for the researchers in the house, we need to innovatively stick together and think together and work together to address this hemorrhage. We know the leading causes of that, and the factors that can be prevented need interventions during ANC. I will also mention that most of our women actually conceive while they are anemic. So as you know, any loss of blood during childbirth, when you're already anemic, really compromises your health status and can easily lead you into BPH. Interventions during ANC still accounting for over 65% of the maternal death. So the factors in there are preventable, especially screening for hemoglobin and other infections. Guidelines exist for management of the common conditions causing maternal death. We seem to have done quite well on guidelines, and the team that's responsible, thank you so much, the NASMEC subcommittees. Now, for some reason, I felt I should keep probing in terms of questions. Now, this is where we need to think harder and think differently. Will high ANC coverage without quality provide, I think it's more of a sentiment. Will high ANC coverage without quality provide the desired outcomes? That should have been the question. In the subsequent graphs, we are going to look at how we fare around the different, and I will probably conclude this, but we are going to look at how we fare against some of the ANC indicators that are really targeted for antenatal care. The first one is the percentage of pregnant women attending first ANC visit. We are very interested in making sure that we get mothers early enough while they are pregnant in the first 12 weeks. And in the blue text, you can see the rates have stagnated at 36.1 for first ANC visits in the first trimester. This is not good. I know there are a bit of cultural issues here, but this is where we probably need our VHTs. We need a strong community program. This is not good enough. The intervention packages that we can receive in the first trimester are missed, but also from a scientific perspective, you also know that embryology, most of the embryological stages happen within the first trimester. But if you already have infections that are not screened, we are likely to have very many issues with our baby. We are very good at mapping where the biggest burden is. Kampala and Bunyoro and Central recorded the lowest rates. This Kampala is urban. You'd expect the access to be very good. I'm happy Mbarara is not here, but I think you'll come some point, doctors, the DHO and your team. So, so we have a big issue, antenatal care package. So on the outlook, when you look at our numbers, 95, 90, 90, 90, 90, 90, but look at our interest in having mothers come or moms come to us in the first trimester, still very low. It's an issue of quality. It's an issue of engagement. It's an issue of getting down to where these mothers are in the communities. So the small graphs down there are trying to break down the regional variations. And that is what I managed to capture in the summary. Some regions are doing well, others are doing very badly. And so that is an issue for us. Here, percentage of women attending the fourth antenatal visit. Yeah, fourth antenatal visit, as we emphasize 8 antenatal contacts. Our VHTs, this is a message that we would want to be very strong, that we want women to interface with the healthcare system for at least more than 4 times. Even 8 times is okay. So our guideline is very clear. We are encouraging 8 antenatal contacts. The health problems, as you can see here, the health problems experienced by pregnant women can be prevented, detected, and treated during ANC visits. 58% of pregnant women attended at least 4 antenatal care visits. We would expect now, actually we had a very big problem when we were approving these new guidelines. The senior top management of Ministry of Health, the ministers asked me, but you failed to achieve 100% of the 4 visits. Why do you want 8 contacts now? I said, don't worry, we shall get there. So I was banking on people like Sebutinde to help me get to 100%. But you see now, despite the big coverage, the smaller issues, the details, how many women are completing 4 antenatal visits or contacts? So 58%, slightly above 50. 8% of the national target attained by end of August. So we set our national target to be 50 because of the performance of this. Ideally, it should be 100, but because of the poor performance, most women come in late. I think the midwives in the house know that women were only coming in to get the ANC card. But we need to change this paradigm. We need to change the story. We need to educate them about the importance of antenatal care. 93.3 of the regions attained the national target of 50%. This is quite well performed across the region, but because the target is also low, but we are going to increase this target now to around 90% now that we are performing better. South Central is a priority. Still, South Central is where Kampala is. There's still challenges. Women are not attending antenatal care. So again, as I mentioned, we needed to treat, one of the reasons for the new antenatal care model was to be able to treat infections identified early, an entry point to many health interventions like malaria. I want to say that when you look at this graph, we have IPT, the intermittent presumptive treatment, 2 and 3 are below the national target. only 56% of the pregnant women received IPT3, whereas 64 received IPT2. And these are not very good indicators on our quality. This emphasizes why we need such a very client-centered or patient-centered approach to understand their issues and be able to address them so that we can improve most of these indicators. Of course, Kampala is the most problematic one, and someone should have a special study, but I think it's more in the Makerere region, so the Makerere team. But Mbarara can also extend there. Ankole and Kigezi reported the highest. So Ankole, you reported the highest number of women receiving IPT, 68%. But the national average now has moved to around 70. So you should be able to also improve on that. I was also interested in knowing percentage of pregnant women receiving iron folate. Now, this would expect this to be very obvious and given or even hit the target there and then. But only 70% of pregnant women received, and only Kigezi attained the national target of 80%. So this analysis speaks into our ANC. I started by presenting a very good coverage, and all of us got happy. But when you go into the details, what in our package are we able to deliver? Are we delivering the package as per the standards of care or per the standards prescribed? So for me, we have work to do, and this project is really timely. I love this one so much. Percentage of pregnant women tested for anemia using the HB test at ANC1, only 21.2% tested. Improved screening of pregnant women. This is very critical. Remember, you link this with PPH. Women are getting pregnant while anemic, actually almost 50%. And we are seeing them not being screened. So the risk is not identified, risk is not managed, so they end up giving birth and we just drop into PPH. Bunyoro, Karamoja, and Teso were the least performing by that time. So those were challenges around ANC. All these are packages, percentage of women pregnant, dewormed, or receiving albendazole. But my purpose was really to say that our ANC package, our guidelines are very clear. It's rich enough, and all we need to do is to make sure that we individualize or we encourage this patient-centered care into our routine ANC to ensure that we are able to improve on the quality. Our issues really seem to be on quality. Coverage seems to be improving. It's improving very fast. So in the new ANC guidelines, we've also added that women should receive an ultrasound scan during any of the ANC visits. This, of course, is still affected grossly by our coverage. We don't have so many ultrasound scans out there. Even those which are there, they don't have people to operate them. I know of Kabohe, they don't have, it is as brand new, it is kept in the store, but we are working on that. So we have an issue, it's an important intervention in our package. We need to look at it, we need to ensure that some of these indicators come up, especially there's absolutely no way we are going to manage our high-risk mothers without the presence of and functionality of these gadgets. So 26.3 is still very low, and in some regions as low as 6.3 is really not good for our quality. So as I come to an end, we are also interested in early identification of, we call it the triple elimination. We are focusing on syphilis, focusing on hepatitis B, and HIV. We are emphasizing elimination of these triple three diseases through by cutting off the vertical transmission. And this is how we perform. 91% of pregnant women were tested for syphilis. And in some areas, because for me, I look at the national level, so there's a lot of regional variation. Would expect all of them to be 100% because if we got a child with HIV and they've been put in kits, so they are much easier to administer. Bunyoro and Kigezi reported the highest, which is okay. And we really want to emphasize for our midwives here that triple elimination is something that we must score 100. And I hope that the study areas will look at this and ensure. But the other way to look at this is making it simple and probably involving the beneficiaries. We want to develop a system of, through the entry point of self-care. I don't know what self-care is in Runyankore, but I think in Uganda they twefeko, something, okwefaho. Through a self-care system, where we would like to raise the literacy levels of mothers. And we shall work very closely with our VHTs. We want to raise the literacy levels of our mothers to ensure that they are, despite being on the demand side, they are able to initiate or to remind health workers that I need this test, I need to have this test, I don't know about my HB status, I need to have my syphilis test, so that we can share responsibility. We've seen a scenario where healthcare workers miss out on some of these key investigations just because mothers probably didn't know that they need them. So I've just been reading what Dr. Mujenyi gave me, the messages. We want to see a communication strategy that is so simplified that the mother knows over my pregnancy, I'm going to be tested for HIV, I'm going to be tested for Chibumba, I'm going to be tested, I think Chibumba is liver, hepatitis, eh? I'm going to be tested for syphilis, is Binyoro. I'm going to be, so that the demand side can actually be proactively involved in requesting for some of these tests. Even if they don't get them, they feel an obligation to go and get them. So we are trying to work on that. It involves an attitude, but also I think this project, Cathylyn, should really focus on that. Let the mothers demand that they need to know if I'm free of syphilis, I need to know HIV status, and all those other areas. So another thing that we are also very interested in is NC attendance by pregnant women aged 19 and below. We have one of the highest teenage pregnancy rates in the world, I think around 25%, and has remained so for the last 20 years. So we need to see that these teenagers who are actually babies becoming mothers are given a special focus because of their uniqueness. And we also note that 18% of the pregnant women attending ANC were aged that. And we see this problem more in Lango, Bukedi, and Bugisu, but it's widespread, it's everywhere. It's everywhere in the country, and in the last couple of months, I think you had very heated debates from Ministry of Health and Parliament when one of our colleagues prescribed contraception, which I also believe can work. If adolescents are sexually active, there is absolutely no reason why we should bury our heads in the sand. Adolescents who are sexually active should be given an opportunity. We don't have it in policy, it's my personal opinion. But I really think if adolescents are sexually active, they should have access to information and should have access to commodities. So it's them to choose. We are not forcing them, but they should have access. So when we say we are not giving them access, we are bringing so many problems that I cannot enumerate here. The leading cause of death among women 24 and below is abortion-related complications in Uganda. for the last 5 years. So these abortions are coming in because of an intended pregnancy because of lack of family planning methods and information, and at the end of the day, we have very serious complications to deal with. So, so many districts in Uganda, as you can see this map, the dark red, their teenage pregnancies seems to be a corridor following the River Nile. But also you can see in some wests, but that one must be one of my districts, Kabarore. Teenage pregnancy is a big issue, but none of us is actually safe. You can see the others are in their age range of 14 and 23. So really, teenage pregnancy is a big challenge. I want to come to a conclusion. And this is my conclusion, given what the analysis talks about. In conclusion, we need to collectively address the quality of our antenatal care. I've been trying to explain this all through. We seem to have done extremely well on coverage. We continue to do well on coverage. The mothers are coming, but the quality of care. I was reading a presentation, a paper from one of our East African countries, and the amount of time our midwives spend with mothers is so small. I don't know if there's any midwife here who can give us roughly how long they spend with one mother. The midwives, how long do you spend with a mother? Feel free to answer. Just any answer is correct. How long on average do you spend with a mother? No, they can't speak openly. No, roughly. And I'm sure you don't know the WHO recommendation. The microphone has disappeared. And they can use this one. Any brave midwife? Don't worry, any answer is correct.
Thank you all. I'm called Daphne Chasim, midwife from the Regional Referral Hospital. As I may say, the time we spend with mothers, it depends on on one mother, depends on the shift we are working. Because they are divided shifts, someone could be for day, evening, and night. If we are for night shift, we tend to spend a lot of time with that mother. Approximately 3 hours. I know why people could be saying, but also it depends on how many mothers do you have on that shift.
Does anyone want to give an alternative answer? You know, she reminds me of when we were practicing midwifery. Whenever we would ask the midwives, how, a qualitative question, what is the fetal heart rate? Fetal heart rate, they say, it is fast. How fast is fast? It is fast, doctor, come. So, over to you, midwife.
Yeah, thank you. During antenatal, me personally, I usually attend this mother like within 5 to 10 minutes.
Thank you. That's realistic. That's very realistic. Now, yeah, 3 hours. That's very realistic. There could be, the scholars here can help us understand why, because there is a standard of WHO, 40 minutes. So the scholars here can help us understand, is it an issue of human resource? Is it an issue of attitudes? Something, do you want to make a try? You remember even in the OPD, there is a next syndrome. Next syndrome. Before a patient finishes, someone has. Yes, Dr. Septine.
Yes, the time every health worker, but in particular now we're talking about a midwife. The recommendation by WHO is 30 to 40 minutes. That's the recommendation. But in practice, it is very short. And I loved her answer. We've been struggling with our teams to ask them, because we know there are many mothers waiting. So as much as time phrase that we use should be within the 30 to 40 minutes. Try as much as possible to be within that range. Secondly, that time must include the touch. The touch. Many times, our teams, I go out there and I find them conducting things remotely. Tandama, Jiroti, Atiterera, and you are instructing, like from Tandama, Tembech Tanda, Atiterera. No. That time should include, Professor, excuse me, the time of touch. That touch is magical. I'll tell you as a clinician, it is magical. It restores trust and confidence. It gives hope. It is therapeutic. The touch of a midwife, the touch of a doctor to this mother will release many things, including the hormone you want to release for the baby to come out. The obstetricians will tell us. Please touch.
Thank you.
Thank you. Unfortunately, in the 30 to 40 minutes, my medical officer at the health center 4 will have finished a ward round in 3 wards.
So I thank you so much. Keynote addresses, usually there are no questions, so I felt that we could get that contribution from Dr. Sebutinde, who has done quite very well. And colleagues, if there's anything that we want to move away from all the nice pictures, graphs I've presented, or whatever narrative, we need to move away from here with the word quality ANC. It's no longer business as usual, ANC, come, next, no. As long as we don't have quality, we have seen in some regions of Uganda, mothers attend ANC 1 and 2 in healthcare facilities, then they go to TBS. It's going to happen as long as the experience of care, the satisfaction of this mother, which we must be cognizant about, does not meet her expectations. They will definitely not even come and deliver from our facilities. Working with them on their birth preparedness plans is also very critical. During the antenatal care, the quality antenatal care, it's a discussion. It's a continuous discussion. Encouraging them to take up family planning, it's a continuous discussion. We have a golden opportunity to interface with mothers during antenatal care. I want to conclude by recognizing our collaborators. I just want to say thank you so much, and we can clap for them. And lastly, when Cathylyn approached me for a letter of support, I didn't know she was coming to bring such strong and good news. So when Dr. Mujenyi was insisting that, Dr. Mugayu, you have to come, I said, but why should I come? I said, but you're the one who gave us this letter of recommendation. I said, okay, if that is the reason, then I have to be here myself. It was such a busy week, but I had to be here myself. I want to thank you. Thank you, everyone. Thank you for listening to me.
Thank you so much, Dr. Richards. Dr. Richards, while you were speaking to us, you gave us statistics. And of recent, social media has hit Dr. Sebutinde's district, where I don't belong sometimes. But every time you introduce yourself at a conference outside Mbarara, you're like, my name is Angela Nakato from Mbarara. People's faces go like, So you brought even statistics about, we know the statistics that are causing, for the sake of Professor Gaba, they said Mbarara district has the highest HIV prevalence. So now even maternal death, we are somewhere among the best, the high numbers. It's really a pain, but Dr. Sebutinde, on your feet, hit the ground running. We have to change these statistics come next year. Deal or no deal? Deal. Yes. Ladies and gentlemen, Dr. Mujenyi introduced Father Bash Foundation, and he talked about the hospital staff. Even us in the baby's home, we are there. You didn't tell us to stand up. Father Bash Foundation has schools, hospital, Divine Mercy, takes care of abandoned children, and of late, the numbers are in the hundreds of abandoned babies. They even have a teen home. They have graduates and graduates. A hand clap to Father Bash Foundation. He could not work alone if we were not a team. Thank you, my relatives from the hospital. You never see us because we're always on the bouncing castle playing, enjoying the swings and everywhere. And allow me at this moment to also thank Ester's parents for choosing the right name for their daughter. You know, a name has an impact on a child. Who is Esther in the Bible? Amen, pastors in the house? Who was Esther in the Bible? A queen, my wife. No. Esther in the Bible was the favored girl. Mujen, you're spoiling my class. What's your problem? So, for giving Esther the right name, if you had called her, let me leave that name. Fungura. Fokorora. Fokorora. Akatushara. She would be a loss to us. But calling her Esther, Cathylyn, and God loves us. God really loved us. Thank you for choosing the right names. And people in the house who are having babies, the name of the year is? Good. We're in class. I love my class. Ladies and gentlemen, allow me to welcome and recognize another person from the Basai's office, Mr. Mutunji. Frank, please stand up for recognition. Another auditor. Thank you for coming and being with us. Ladies and gentlemen, technology is the way to go. Welcome the Dean, Faculty of Computing and Informatics, Dr. Everest Nabasa. Thank you, Dean, for being with us. We also have someone behind the Vice Chancellor's success. Okay, minus me. Sharon, please stand up for recognition. Sharon is the PS to the Vice Chancellor. All the letters you see, it's Sharon. The handwriting is mine, but we wouldn't be here. Allow me, let's put our hands together, ladies and gentlemen, for the influencers and the communication crew from Mbarara University. Please stand up for recognition. The communication crew. I know you're short, but try to stand on your heels. Yes. Ladies and gentlemen, let's follow on Twitter, Facebook, and our Twitter handle is Mbarara UST. And then Facebook is Mbarara University of S&T. Instagram has the same name. But Support Moms has gotten a Twitter handle. Support Moms 23 is the Twitter handle. At Support Moms 23 is the Twitter handle. Right now, ladies and gentlemen, with supporting and tweeting and everything, we have reached just by the morning 11 million views. And we're tagging all our partners. The way to go is social media. Please, let's put our hands together for the social media and influencers in the house. Allow me to welcome and recognize people who always support, people who support moms. Those are the lab scientists. They like pricking. I hate that prick. You always, even when they're not pricking. Please, the lab scientists in the house, stand up for recognition. Stand up with pride, and I talk about you. Thank you for pricking our fingers even when we don't want. You find the veins, you locate them. Thank you, especially those that are really hard to find. Ladies and gentlemen, we have tea at the back in case you need a snack for housekeeping purposes. In all this, the time we've been waiting for has come. DJ, you create some tension. Do-do-do-do. Ladies and gentlemen, I do not, again, I'll say, I do not have the right honor and words to introduce her. But they say, birds of the same feathers flock together. When you tag along, you'll find them. The other time you talked in my microphone, I have to be careful. Birds of the same feathers flock together. In my local language, they say, the rich and the rich always blend. That's why the hair looks for the beard and they connect. Yeah? So that's my language. Abagaga na abagaga. So the hair connects with the beard. It doesn't connect to anything else because they feel each other's connection. Allow me invite someone to talk about Dr. Esther, who is going to be our next speaker. This person is DJ. You're paid to create tension. A multiple principal investigator of building implementation science capacity in non-communicable diseases. She is a deputy hub director of Mbarara University of Science and Technology Data Science Research Hub. This person has stood the time and tests of research and grant writing. She has visited the prestigious universities in the world, Harvard being top. She has made connections and impacted people's lives with her research. Even when they tried to boom her down, she stood the winds and stood and flew higher than the clouds. Ladies and gentlemen, allow me to welcome Dr. Edith Wakida to introduce our keynote speaker. I want to have a CV like yours.
Thank you very much, Angela. This is a difficult task, but I'll take the honor to speak about my friend, Ester Cathylyn Atukunda. She's my colleague, she's my friend, she's Godi's wife, she's a mother, a model female scientist. Ester is a pharmacoepidemiologist and senior lecturer in the Department of Pharmacy at Mbarara University of Science and Technology. She has invested her time in investigating alternative, user-centered, appropriate medicine and intervention use for low-resource settings. Ester, formerly a K43 awardee, also former awardee of the CIFA grant, is now the person we are celebrating today, the RO1, Support Moms. Ester, we are proud of you. Life may be rough, but you're focused. Please come and speak to your audience. Congratulations.
Good morning, colleagues. I am not used to these political gatherings, and I'm not a very good speaker. So I will try today. I'm more of a writer than a speaker. So I hope we'll be able to get through with me and be patient with me as we navigate this. I am very honored today, and thank you for all of you for honoring our invitation. I'm really humbled to be here today to speak to each one of you in your different capacities. All protocol observed, and I think I will talk about specific people towards the end of my presentation. So before my nerves rip me apart, let me just go through the presentation, and then as I catch the nerves along the way, then we can have a more cordial discussion. Thank you so much. So Today, I'm going to talk about Support Moms Uganda. And this is an area for which I'm very, 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 very passionate about. For many reasons. Simply because of how we have grown up, how I have grown up, but also the interest that I share with my better half, Dr. Mjenyi Godfrey. So as we live, as we move, as we interact, he's the source of my ideas. He's the wind beneath my wings. So in an environment like this, when we have unacceptably high maternal mortality rates, every time he comes from the ward, of course he has to vent to somebody. So he comes and tells me all his escapides, and I am just numb. I don't have the tools of how we can resolve some of his frustrations. So I resolved over time for him being the clinician, me being the epidemiologist, to do the research, and we support each other to find simple but working solutions for our mothers and our frustrations in maternal health space. And so, I'm going to start by talking about antenatal and skilled birth, which are the key pillars of preventing maternal mortality and perinatal mortality deaths. I'm very glad Dr. Mugahi has already done part of my work, but I'm going to point out key issues that really stimulate this debate and eventually introduce you to the real gist of the support moms and where it emanated from. We notice that antenatal care is very key in detection, not only detection, but we have to be able to detect these complications and risks and treat them or manage them very early on. And secondly, or thirdly, we have to be able to identify high-risk women early enough, as early as first trimester, to be able to ensure that they deliver in a skilled facility. That is very key. And as Dr. Mugahi was running through the slides, you notice that the attendance of at least 4 antenatal visits in Uganda is less than 60%. That is very low, out of the recommended 8. And of course, amongst the maternal deaths that were reported last year, only 58% had attended a single antenatal care visit. Less than 70%, or more than 70%, so to say, they attend the first antenatal visit way after 5 months of pregnancy. And he emphasized that most of the risks could and can be identified at least in the first trimester. So you see how that rolls into the second trimester and then third trimester, and then we have a lot of things to deal with. So let me run through the recent data that was presented at the Safe Motherhood Conference for the 2022-2023, just to give us an idea of this spin-off. From the data that was presented, yes, given, maternal mortality rate has dropped from 336 to 189 per 100,000 live births. But this is still unacceptably high, and we are yet to see whether we're going to maintain this trend for the next 2, 3, 4, 5 years. We were also told that the perinatal mortality rates halved last year because that UDHS put it at 40, but they reported it at 20 per 1,000 live births. Now, this is where the gist of the conversation comes. We noted from the data-driven documents that were given to us on that day, that was 2 weeks ago, that 54% of deliveries did happen at the non-comprehensive emergency maternal neonatal centers. And these are health center 2s and health center 3s. Take note that on health center 2s, these are non-functional health centers because we do not have oxytocin there on essential medicine list package. They do not get any. But we had a very high number of mothers delivering from health center 2 in this country. So we also noted more maternal deaths at health center 4, which is contributing to 172. General hospitals, 380. Referral and large PNFPs, these are private not-for-profit hospitals, which had the highest share at 648. And most of these deaths were due to late referrals. In other words, mothers died within 24 hours of arrival. In the same report, Ministry of Health reported poor health-seeking behaviors. I was waiting for Dr. Mugahi to make that emphasis because that was a key issue that directly contributed to the late referral, to the first delay, for which women delayed a lot in the villages and they arrived a little bit late. And the contribution of first delay, Dr. Sebutinde, you're one of the highest contributors in Ankole at 49%. It's not for clapping, but it's for improving. So, much as we noticed that maternal mortality rates dropped, but they remain unacceptably high, despite improvement from our colleagues at the ministry. You have improved on the supply side, you have tried to improve on the number of skilled delivery attendants at the health facilities, but also increase the number of facilities which are functional. We all have a call to action towards meeting the sustainable development goals. All of us in this room, in your own capacities. One of the main reasons why we have a huge call to action is that we all know that maternal mortality rate is costly, both socially, economically, physically, emotionally, and it's devastating. And therefore, we are not shy to notice that there is a very high and urgent need for adaptable and context-specific interventions that will boost antenatal, not only antenatal attendance, but also maternal service utilization across the whole country to be able to reduce this very big elephant in the room. And we have a very big mandate because WHO recommends that we need every individual, every stakeholder, every participant, every individual, or every researcher, academician, everyone in your capacity. We have the mandate to be able to identify and scale up those interventions that we feel can improve access and use of these maternity health services, especially the ones that are already available within our setting. Let me make for you some damning statistics right here. If we had at least an identification or a scaling or evaluation of some of these interventions, WHO does indicate that these context-specific interventions have a potential of reducing or preventing over 800,000 stillbirths, over 1.2 million neonatal deaths and 166,000 maternal deaths annually across low and middle income countries. That's a big one. And what does it take us? As scientists, as policymakers, as Ministry of Health officials, as midwives, as academicians in this room, as a social supporter to a woman, as a spouse, as an individual, as a neighbor, as a community member. We have to engage multi-level, multi-sectoral, multi-pronged approaches towards tackling this scourge of maternal mortality. It can't be a one-way. And I picked one take-home message from Dr. Mugahi's conversation when we had run for the National Safe Motherhood Conference. And he stated, and I wanted to quote him today, that we need to merge all efforts that align all partners that are working towards the same goal of reducing maternal mortality rate, because it's not a one-man show. So we have to combine effort. We have to combine health systems, functionalizing health systems on one end. We have to make sure we improve respectful maternal care. Midwives are here. Women, when they complain that midwives have a bad attitude, they are rude, they chase them from facilities, they don't want to deal with ABCD, you know what we do down there. We have to have that multi-pronged approach as a community to make sure that we tackle this scourge together to be able to reduce institutional maternal mortality rate, but also community maternal mortality rate. It wouldn't want to be your mother, it wouldn't want to be your sister, it wouldn't want to be your not mother-in-law. Mother-in-laws don't really produce, but your spouse and every other person that will be in that situation. And so we have to come as a community and combine our efforts. And one of the approaches that I was triggered to look at was through community-level approaches that could engage and mobilize communities to be able to mobilize what we have, the resources we have, to be able to mobilize support and to improve service utilization within the communities of these mothers. Of course, Dr. Mugahi would prioritize funding, budgeting to where, our local language says, take a sente wolaba, isn't it? Put money where you can see need. So prioritizing and all. What is the role of digital health? Because this is what I want to talk about today. We all know what digital health is, and we need to harness the power of information in this digital era. With information, we won't go wrong, but which kind of information? Because there is a lot of information out there. Is it the targeted information? Is it the good, critical, health, tailored information that we need? Is it, what kind of information? Can it be trusted? We need this critical information to be able to access the masses down to the communities for which we are targeting. And evidence has shown that health interventions are very practical, but not only practical, they are effective. And they can be scalable because they reach masses in a very short time. And with this approach, we could be able to improve health outcomes, definitely. These health interventions, they are effective also in helping individuals to internalize the different risks that come along with pregnancies, the perceived need to access care in time, but also can empower individuals to seek and address specific concerns and health concerns that could eventually help them to strengthen informed decisions to seek care in time to be able to be helped in the available health centers. If we enable people to also be aware or be health aware or get this information, they would also be able to use this information. Somehow you get empowered knowing that you know information about, for example, birth preparedness, HIV in pregnancy, malaria, how you can, detect danger signs, what you need to look out, and that information empowers us through knowledge transfer, and definitely it could boost and stimulate and facilitate our women or communities to seek care in time and reduce the maternal mortality rate. I want to talk about the concept of social support in our environment. Africans, not only Africans, but in our setting here in Uganda, it takes a village to raise a child, right? But it also takes a village to treat a woman, isn't it? To protect a woman, for example. It takes a community concerted effort to rally around this woman to make sure that we do not lose this woman. Because we said that maternal mortality rate is very costly at a family level, at an individual level, and at a community level. So we are triggering and mobilizing our communities through the available resources to be able to drum up support for these women in the villages. And why do we need social support? We know that a lot of our women, for example, do not have financial independence. Decision-making, gender roles, power dynamics that are available in our communities, they do not specifically work for these women who need to make a quick decision to access care in time. So what are we going to do? Social support can be physical, can be financial, can be emotional. And we have learned through different literature and through different evidence that digital interventions, they indeed bolster the access to social support. And this social support is most of the time, or in many times, what women need to access the facilities that are available, healthcare, and it's a key pillar in improving pregnancy experience. You can imagine if you walked into a facility surrounded by your significant others, gathering around or mobilize for you the transport for you to be able to access a facility in time. Or maybe you have a labor companion by your side who is going to soothe your back, or maybe to bring you a cup of, not coffee, we usually use tea bags. What do you midwives use? Tea leaves. And that kind of component, I think it would make a very big difference for these women. And in some data, it has been said that this presence of social support, it is likely to improve the anxiety, but also depression, in case these women, need emotional or physical support. For example, if you need someone to live at your house for you to be able to access a facility. Most of women delay to go to facilities because they have 5 children at home, or maybe they have relatives and they do not have someone to live them with as they transition to go and look for care. And so they get stuck around there, and with our traditional men, they have gone to look for money in a nearest trading center, or maybe they are gone drinking. And so that kind of, dynamic also does affect these women negatively. But also is likely to improve perinatal bonding, because if you have an active or involved a significant other or spouse or mother-in-law or sister or friend, it's likely to improve some of those things. Then we want to talk about partner involvement, which is a very key pillar in social support, but also in promoting family and social structure network, which goes without saying. Financial and emotional coping mechanism, of course, these ones enable women to broker or to, to overcome barriers to health care access. For example, if they do not have food to eat. Dr. Mugai talked about mothers who turn up when they are anemic, but we do not verify that. I am very sure that with a woman who has that social network around them, and they are able to overcome socioeconomic barriers to feeding, to transportation, to, nurturing, to care, to all that, they are likely to thrive and to survive more than, the women that are abandoned. I want to borrow that name. All right, we are on. So how does all this affect access to available services? It goes without saying that health awareness through directed, tailored, and accurate and relevant information on the promoted behavior for which, for example, we are drumming up support for women to attend antenatal care as early as they just recognize that they are pregnant, as early as, 6 weeks, 10 weeks, below 20 weeks. So that is likely to motivate use. I'm going to run through this presentation pretty fast, so bear with me. And then we also know that if you have perceived need, if you know that you require to go to a facility in time and to utilize that facility in time, you are likely to plan ahead of time and make sure you access that service. But also, Dr. Mugahi, we need these facilities that are functional. Because by the time we drum up support for mothers to access these facilities, from the top down, they must make sure that these facilities are functional. Because we are trying to create demand, but also increase demand for these services from the ground up. So the top down, we are asking that, the ministry should be able to make these facilities functional to be able to improve care as well. Now, with social support, I'd already mentioned this, and community engagement, we are likely to improve and motivate healthcare utilization. And through motivating healthcare utilization among our mothers, we are hypothesizing, or we are sure that this can effect behavior change. Few mHealth applications have been taken to scale, and this goes without saying. We have not had mHealth interventions here in Uganda which have been taken to scale and integrated within the routine care of maternal care services. And we will see now our goal for this intervention specifically, we want to transfer knowledge. Not only knowledge, but what is the word? Critical, tailored, and correct knowledge to these mothers. To debunk the misbeliefs that are already there, to debunk the negative psychosocial beliefs that they already have in the communities. For example, some women believe that death is as an act of fatalism. If you want to die today, you will die today after all, even if you go to a facility, even if you go to facility, if God intended to call you today, will still call you in their home or on the road or whatever. So we need to give information to debunk some of these, negative beliefs. And in this, we hope that the women will be able to learn, but not only learn, but internalize and comprehend the information that they are being given through their preferred medium of delivery. And we notice we are dealing with an illiterate, moderately illiterate population. So you have to be cognizant of the different medium for which you're going to deliver this message, but also the context for which they understand, which I'm going to talk about in a minute. And then lastly, you have to promote and encourage positive behavior. And this is how we are going to do it. We have, in the previous stakeholder interviews, we realized that most of the women who were engaged in home births, because we interviewed women who were involved in home births, and their biggest issue was the irresponsive healthcare systems or health centers that they experience when they go to facilities for delivery. Their interface with the midwives that are rude, that have a bad attitude, that abandon them, that yell at them, that have no respect for their culture. We talk about, because there are women who are worried that their placentas will be taken away and they need them for whatever reason at home, so we need to counsel them through these issues. And when we talk about some of these issues, they might sound trivial, but women actually do take them seriously. If you do not engage them and counsel them, you are not likely to see them next time coming to your facility. They will opt to deliver to their neighbor or the traditional birth attendant, who will hold them in a friendly environment, pamper them around and, reassure them and treat them as family. We do not treat our women as family. And that's where the concept of respectful maternity care will come through on the aspect of the health facility system delivery. So we tended to develop a patient-centered tool, and this is what our goal was. We wanted to use this tool, easy to use, one that would engage users, one that was educative, very, very fine, plain language that you would engage with, and you would educative and prepare users to use the promoted health facilities or skill delivery, but also wanted to motivate these users or women in our villages and drum up support or mobilize support for them to be able to overcome the socio-economic barriers that could hinder them from accessing the healthcare services. And of course, we wanted to tailor them and personalize them. So what was our premise? We noted that Uganda has over 30 million people, mostly adults, that have access to mobile phones. That's a given. Everybody here has a mobile phone. But what do you use your phone for? WhatsApp, Twitter, call a neighbor, make progi, and it ends there. But can we harness that to promote health? And we noted that more than 71% of these users actually are connected to a basic feature phone, not your traditional Android phone. And these are our key targets. 71% is quite a big number to leave behind. So as tapping in with your Android phone, if you designed an intervention that is not compatible with what 71% of Ugandans do have, then your intervention functionality is flawed, isn't it? Because it's not accessible, it's not usable, it's not useful for those 71% users. And from the literature, we noted that more than 65% are low literacy users on those mobile phones. So we needed to also tackle and access that number to be able to put it on board. And so our premise generally was, one, to improve health awareness, but also motivate healthcare utilization, which are key elements of developing developing effective healthcare, rather behavior change interventions that are workable, but are also scalable. We aimed at key innovations for this particular intervention. But then we noted with concern from the literature that not all interventions end up working. Some are top-down, some are imported from wherever they're imported, or some look glamorous, they have the right data, they are promising, but not all of them end up working. So we are interested in creating simple solutions that work for our communities. So this is what we created for this intervention. We needed to tailor it to user needs, to include preferred content. What did they need in this content? What kind of information are they lacking? What kind of information do they need in this journey, in this pregnancy journey of theirs? What would they want to learn about? What are those specific things that bother them that we could engage them on and give them the information, not only the information, but in the language that they understand, and be delivered in a medium which is compatible with their phone types, but also which is compatible with their preference, in a preferred time of their need. If it is, they are likely to receive your phone call in the morning before their significant other leaves, so that it can, be discussed over, I need some money to go because, whatever, or do you need them at night, at what time, customize what they will really need to be able to optimize intervention delivery. Secondly, we noted that we have a high resource in our community. We needed to mobilize and engage the social network, existing social network, around the women that we are targeting, to be able to mobilize for them the needed social support, for them to be able to access care. Because if you are giving out money, if you are doing an intervention of, I will give you 20,000 every week. So the study that gives you, is that sustainable? That wouldn't. So we need to mobilize the already existing network of friends, of relatives, of significant others to be able to provide this needed social support. We have already talked about how important social support is very crucial. And we have utilized it in other infectious diseases, and it has worked perfectly well to improve adherence. We have utilized it in TB, in HIV, in malaria, in other infectious diseases. So why not incorporate that important component and pillar to be able to drum up support for our mothers? So we also needed to harness the existence and involvement of VHTs, because the VHTs are the closest to these mothers. They are centered in the villages where these mothers are. They need to be connected, they need to be engaged and become part of the powerful addition of the women's social network to be able to mobilize and drum up support for these women to access care. And all these involvement on a multi-level, multi-sectoral, or multi-pronged approaches would create a synergistic impact through different ways to be able to help these mothers, and through a low-cost technology, because we are not going to buy phones and supply them. We are utilizing the already available resources in the community. You have access to the mobile phone, you have access to social networks, so we want to engage them and mobilize them and drum up support around this individual to make sure that we help them access care in time. And all this has the potential, of course, one, to potentially catalyze scalable individualized maternity care. As Professor Mbarara has already mentioned, we needed to center it here to make sure we have a homegrown, our thing that works for these women. Based on what we have, the resources we have, what the women needs, their perceptions, their experiences, and their exposure. And definitely that would facilitate long-term use and engagement. So we created an intervention that is compatible with available local feature funds, which were 78% owned from the population that we had in the pilot. And this would help us to engage, to facilitate end user engagement. So from the interviews, of course, that I'll be talking about later, we have the illiterate women who can't read text. And so they also opted for audio, because you can listen to a message that is recorded to your favorite midwife within your community with an accent that you can understand. And so they are able to relate in that kind of way. So these delivery mediums, mixture of these delivery mediums for both literate and illiterate individuals would, complement each other. We used available resources, as I mentioned earlier, and of course we hypothesized that this would motivate, educate, shape, but also be useful to the women that required this intervention. So in a nutshell, we incorporated women's expectations, experiences, perceptions, and choices of a familiar mHealth-based technology that would communicate targeted, not only targeted, but health-related information. But we also hope that it would motivate and mobilize support for these women to seek professional maternity care within their local communities. So that was the whole target, right? But also we noticed that this intervention was subject to standard limitation of phone ownership. Not everybody would own a phone. And so we opted for access to a phone within your household. Because if I sent a message within your household for which you can access, then that is as good as ownership. Because if you bank on ownership, we noticed in the statistics that the percentage of ownership might be low, but access is almost 100%. Type and network challenges. So I'm going to run you very briefly to what we are able to do and how this app or intervention looks like. So we enrolled key informant interviews at the start of this pilot, and we interviewed 30 healthcare providers and women to determine the gaps that were there, to derive the content, learn about the content, what their mode of delivery would be, what they would prefer, the social networks and how they interacted with them and how useful they would be and what role they have within the normal life at an individual, at society level, and otherwise. So we use that information to develop content that would be utilized in this mHealth intervention. We included healthcare providers, experts, to sit down and coin content for the 26 topic areas that were identified by these women. And they cut across, you would be very surprised. The women identified 20 topics that they were interested in learning. And some of them were out of scope for your antenatal care policy guidelines, Dr. Mugahi. because you don't talk about things like sex in pregnancy, use of herbal medicines, traveling during pregnancy, and sauna, things. And we actually rated them in terms of their priority, and you'd be surprised that they would rate them, and then those that scored more than 60% were included as the key topics that they needed to learn about pregnancy and childbirth. And so we also involved healthcare providers to add the 6 critical topics that are part of the antenatal care package, to include them within the intervention framework. And so we had a panel discussion of obstetricians, midwives, community health workers drafting the content which these women needed to utilize. And so we went through the prototype design with iStreams, a development to tailor this information in a delivery format for which they proposed, because most of them, more than 70%, wanted it in an audio format because they couldn't read text, or maybe text, But most of them, when we're actually going to do pilot, we realized that they needed both the audio for, the context and listening, but the text message for future reference and sharing with their social networks and their significant others when they return from work, to be able to benchmark and ask for the Kamane to take them to the health facility with evidence of, Musao has told me this, things like that. So we went through testing in 3 iterations where we modified and subjected the same information through audio calls and text messaging to these women, and they made changes over and over in 3 iterations. And then finally we were able to do 2 focus group discussions to refine these messages, and did 5 cognitive interviews before we had the final message prototype that we had ready for pilot. So in our pilot, we had 3 arms. One arm received the routine care of information giving as per Ministry of Health routine antenatal care requires. We had a second arm where we had scheduled messaging to these women, to only women who were enrolled on this program. And then we had the third arm where we engaged the social support network that were inclusive of 2 pre-identified social supporters that were having an existing relationship with these women for at least 2 to 3 years. And then, of course, we did exit interviews, and each arm had 40 of these women. So I'm going to run you through the data that inform the support moms in the next 2-3 minutes, and I'll be out of here. So in our pilot data, we realized that 100% of social supporters, of 100% of women that were engaged on this application, together with their social supporters, attended at least 4 antenatal care visits. When you compare them with 83% in those that were sent text messages to themselves alone, and when you compare with 50% of those that were enrolled on routine care, the normal everyday, antenatal. We also noticed that there were fewer maternal fetal complications when we examined them, or when we did exit interviews at the end. And of course, for those that were enrolled together with their social supporters, we only reported 8%, compared to 13% and 25% in the routine care. And these are statistically significant findings. And lastly, but not least, the individuals that were enrolled with their social networks, they reported receiving higher social support that needed them to access health care in time. And about 30% of enrolled women experience food insecurity, and 30%, of course, reported monthly household income of that and that. But before I get off from this slide, when you see those graphs, you realize that the smallest number of missed antenatal care appointments was on the arm that had their social supporter network enrolled on the application. And of course, they had the highest percentage of skill delivery, 98% vis-a-vis 70%. 90% of those that were in the normal antenatal care arm, 90% missed at least one antenatal care visit appointment. What are our other observations, our key random observations? We observed that there was a high acceptability, feasibility, but 85% of the women that received of the women that were enrolled received over 85% intended messages within 1 hour of dispatcher. I think that is good for our IT and challenges that we have with the internet fluctuations and all that. We also noted that, over 90% found this intervention useful, but not only useful, but it was easy to use for them. They could easily navigate through it. It was appropriate for them, was very compatible with their phones, and 100% would actually recommend it to others. This application has an interactive feature where you can repeat, where you can ask the person speaking to you on the other side to repeat, what is the other one? To repeat, to pause, to continue, and that kind of interaction that we put would help facilitate. They found it really interactive and engaging. For both the intervention groups, of course, which were using this application. We had a very high screen to eligible, and of course, a high eligible total number that completed the study at the end of the day. We didn't have any lost follow-ups. 78% of women used feature phones, like I mentioned earlier. So if you designed a phone that used Android technology, you would lose out on the 78 women that you would want to enroll. So we have, these promising findings that we are armed with to think about what we can do to get out of the small number to extend and evaluate its, implementability and scalability. I will take you through in the next 30 seconds on the qualitative findings that were interesting here. The women described the intervention as useful, but actionable, because they had those action. What can you do when you notice A, B, C, D, E? What would you do to assess for what? What does this mean when you see it? What does such actionable, messages and easy to use? And they mentioned that this was in a trusted, a preferred but familiar environment within the comfort of their home. So they were able to learn much more than, they were able to learn to prepare and take action. Because these messages are very clear. If you notice ABCD, you do ABCD. If you realize ABCD for this, do ABCD. I think some of you have been able to get copies of those text messages and audio messages that we will play for you some examples, and you have the feel of how they were. These messages, most importantly, they stimulated the vital discussions. In our homesteads, normally, a woman cannot stimulate a discussion about anything. Leave alone the Dr. Muyindikes, who are the land one. But ideally,
it is the men who bring the discussion, isn't it? Yeah. So the women were able to tell us that when these messages came up and the special significant others were there, they stimulated some kind of discussion that ended up, discussing about the elephant in the room, about the pregnancy, about their needs, and about the impending appointment. And so they got the leverage to introduce the topic and also discuss something that they had never done before, which was interesting for me. And of course, if you want supper in the night and you don't want to come back home and sleep on the couch, if they ask you for 20,000 to go to the facility, will you leave it or not? You would definitely, most probably will leave it. So the other one, they said the women, they stimulated support mobilization from others to be able to cope with personal needs. Because if a message came through and it was teaching about birth preparedness, what you need for birth preparedness, what you need to be able to deliver in a facility with a skilled health professional, and that kind of conversation, and you know what you need a pair of gloves, maybe you need to prepare, sheets or baby clothes and all that. So it would remain like a hanging reminder that they need to be supported to do some of those things. So tailoring the intervention to their preference in a friendly and familiar tone not only motivated them, but they said that they were encouraged to engage and give attention and also look forward to the next message. And these messages were recorded by one of you, who's a midwife, a regular midwife. Second last that I'll talk about on these findings, customization and these precautionary messages that were sent regularly every week. Women said or reported that they left a ringing, shrill, and lasting effect on them, and this triggered their need to seek care whenever something popped up or whatever they noticed or whenever they felt the need to go. The last one is provision of complementary educational support was very helpful in text format, and they used this for future reference or sharing among their significant others. For example, if someone came and asked them, for you need to take this traditional herbal medicine because it will allow you to fasten your labor, and so they would have a reference. Musawo told me this. You read here. So I think they would have that kind of a safe zone, a fallback on to be able to utilize that information to, to convince their significant others, but also those that are within their social network. So conclusions and way forward. We are still there, we're still together. Can I go? All right. So, 1, we demonstrated that developing a novel patient-centered and customized audio SMS messaging application that leverages social support networks and relationships is 1, feasible, 2, acceptable, and useful in communicating important, targeted, health-related information in our setting. Let that first sink in. It is feasible, but also acceptable by those users. And so we need to think about it. Next, this patient-centered approach, it indeed supported our rural women in southwestern Uganda to utilize the available maternity services. We saw the tables, right? Numbers don't lie. 3, there was a demonstrated need and demand for these complementary, and the word complementary is underlined. Because even in our audio messages, we emphasized that these messages do not replace the normal antenatal care visits and messages given to you by your healthcare providers. Please visit as scheduled. I think I will play one of the messages and say, so there was a demand, but a need. So, Dr. Mugai, we can't bury ourselves and our heads in the sand. We need to give these women the information that they need, complementary to the normal. Because we have identified that the midwives hardly spend a minute on average with these mothers. Now, what can you teach a mother in 1 minute when they come for antenatal? The fourth one, benefits extended beyond community awareness. Referrals of when you're sick, you're supposed to go to health facility. Please, if you have ever had a C-section, please aim at going to a health facility which does C-section, that is health center 4 and above, and blah, 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 blah. We have noticed that some women end up in facilities that are non-functional, even when they have existing high-risk conditions. And they end up, getting stuck there, and with our poor ambulance system and referral system, catastrophe waits these women. Next, involving healthcare providers and end users in characterizing and formulating these interventions allowed these to be tailored to their needs, but also potential for long-term use. Lastly, we needed to evaluate the maternal fetal outcomes of integrating this intervention into routine care, and this is what was warranted. This was what we're going to do, because mainly we assessed utilization outcomes, and in a pilot, because they are small numbers, we are not able to evaluate maternal fetal outcomes. And this, ladies and gentlemen, is the birth of the Support Moms project, which was funded to be able to take on the work which we had done in the pilot and go ahead to assess the effectiveness, but not only effectiveness, but the implementability. Implementability, I can cut it down into the feasibility on a high scale, but also sustainability. The cost of integrating this into routine care, the cost effectiveness of integrating it into routine care, and what its long-term impact is. So, Dr. Mugai, you're not here by mistake. If God shines on us and we realize that this thing works, we will be on your desk every day, every minute, to be able to help us integrate this. And so when we are setting out to write this grant about 1.5 years ago, these were the statistics at the time between Mbarara and Mitoma district for which we are targeting. Total population, that maternal mortality rates there, we have, Mitoma has no hospital. In Mbarara we have 5 hospitals, but 4 of them are private. We have 2 publicly funded health centers. And Dr. Peter, don't look at Mbarara and then you say this is your Mbarara or Dr. Undi's Mbarara. Mbarara at that time was Mbarara district and city. So we will split it, don't worry. Mitoma had only 1 health center, 4 publicly funded health center, 3 is 10 vis-a-vis 6. VHTs, they estimated 46 to 43, and all others. So the total number of health care providers in Mbarara were estimated at 256 vis-a-vis 100 and what. So they had comparative numbers, but importantly, Mitoma is at the border with Congo. It has special other features that we are looking at in comparison to be able to include it this. So, in this project, which we are launching today, we intend to enroll a cohort of 824 adult pregnant women together with their 2 pre-identified social supporters. And these women should be below 20 weeks of amenorrhea, and they shouldn't have access to antenatal care. We will identify, screen them through the VHTs who are here, and this is the only slide that I'm going to talk about this, this project. So bear with me, in 2 minutes I should be out of your hair. And we will be recruiting women who are living 10 kilometers within a publicly funded EMO facility in Mbarara and Mitoma, randomized in one ratio of 1:1 to any of those arms, which I don't want to talk about now, but we'll follow them until after delivery. So, we have a calling, ladies and gentlemen. Each one of us has a calling of making sure that every mother and newborn counts. We need to reach every woman in every local facility, in every local village, in every local council. And we have to leave no one behind. And this is what we aim at. We have to engage all those women through our VHTs, make sure we drum and mobilize them, the support they need, engage them to be able to access the facility. And as I was beginning this talk, I said, our target is to create demand for these services. We don't need to know, Dr. Mugai, whether you're going to be increasing midwives more or restocking them, but we're aiming at having all women know how to demand for the services, create demand, improve demand, look for every health facility where it is, and make sure they deliver in the presence of a skilled health professional. I'm going to talk about, lastly, my very, very own team members who have been doing this with me. This journey can potentially be an extremely lonely journey, especially if you do not have the stamina, if you do not have the passion, if you do not have where you are grounded from. And I said this is a topic that is very close to my heart, but it was eased by a very great support team of mentors since 2009 when I set off to do this. I'll give you a very short story. When we were 8, I think about 6, 7 years, we were transferred to live with our maternal uncle. So the woman whom we were living with had a pregnancy. She had, I think she was due for her 3rd pregnancy. I'd never seen her going to any antenatal visit. I'd never seen her going to any hospital. Nothing. And so she used to have her babies at home. And us being there, we were like the maids of the house. And so one morning, as we were preparing to go to school, we hear a very loud noise from our, not mud and rattle, some, not so nice, mud and, let's take it at that, mud and wattle, grass thatched house. And so we come to see what was happening. And what I heard from the other room was that she had gone to ease herself. A part of the baby had, I want to say it in a raw sense, I don't want to to say it in a medical sense. I did not know what that meant at the time. Probably she had a macerated stillbirth that she had not noticed for a long time, an IUD, IUFD. In other words, the baby had died in her womb very many weeks and she did not even notice. So there were people to do the stretchers, and I was living deep down in Ishaka. They put her on a stretcher. This was the only human, like a mother in the house who we stayed with, who, you know, cooked for us and did all sorts of things. And so they had to run her to Ishaka, which were kilometers away, on a stretcher. That evening, we had people running across a village. You see, Mama so-and-so has died, Mama so-and-so has died. And we're like, who? But she left here when she was walking. Like, she bled a whole basin of blood. Then I'm like, blood, a whole basin of blood. And then, to cut the story short, she was brought home, we buried, we moved on with our lives. Some of us scattered, ended up where we ended up. But when I had had a ringing motivation to ever know what killed that woman. Of course, in the village, she was bewitched, what, and stories went around. Until when I finished medical school and noticed that one, she had never attended any health facility for either antenatal or for any skilled birth. This was her third. And the bleeding that was mentioned, so the stories came and started piling up. She had indeed died of PPH, secondary to what? Probably secondary to anything, any complication that she, must have, encountered with a complication of having an IUFD for, I don't know for how long. And that is how the story ended. And so, eventually, when I came to marry this gentleman, who was an obstetrician, I thought I'd put those stories behind me, and then he comes with the same stories. Well, so and so died. Yeah, she came in a what, and so she died. And I couldn't help. And she came 2 hours before. And then, you know these stories? And this was stories over dinner, stories over breakfast, stories on the bed, stories on the car, stories on the driveway, stories at a party like we are seated here and she's discussing for you the patients and how they have lost this. And so, ladies and gentlemen, you wouldn't be surprised that I ended up in maternal health. So, my team members, one of the team members that I want to recognize today is Professor Celestino Obua. This gentleman is the MAST VC, but he is the one who introduced me to research in 2009. And in his own words, one time I was doing a research and I was doing a very sticky research on misoprostol. There were pharmaceutical companies writing to me, threatening me, and you cannot be doing that. It's like giving women a can of worms. You cannot, I'm like, that is what is available in our setting. You have to investigate on alternative medicines that are usable in our environment. Yes, the first and basic and most important and standard, gold standard of care is oxytocin. But there are communities in this country who would benefit by even a 20% or even a 10% effectiveness of any medicine because they would never access oxytocin. And so a long email was written of, no, we cannot accept that. We are going to challenge the REC and National Council. You cannot be investigating such a medicine. It's now on essential medicines list, isn't it, in this country? It is on essential medicines list. And I remember Professor Bua wrote an email, and one of the last sentences that I will never forget, and he says, your project or your funding is not a metal jacket. People have the capacity and the zeal to investigate alternative interventions as they deem fit if they are convinced that they are going to help their communities. Thank you, Professor Boa. I never received any other messages. That was the end. I want to recognize Dr. Peter Waiswa in his absentia. He's in Geneva today, but he is a health economist and health systems researcher based at Makerere School of Public Health. He has been very instrumental, and he will lead the cost effectiveness component of this study. Dr. Mjenyi. Dr. Mjenyi Godfrey, stand up, please. This gentleman here is, I've already mentioned it, he's the wind beneath my wings. And as we can notice in this room, I have females in this room, without a supportive spouse, you cannot go far. In our setting here, that is for sure. He has allowed me to shine, he has allowed me to thrive, he has taken care of the kids when I'm not there, as I'm busy, you know, chasing our dream. And thank you so much, Dr. Mjenyi. I don't take this for granted. Of course, that goes without saying. Katrina Mjenyi is here representing the kids. Please convey our warm, heartfelt for your patience. And sometimes they don't get to see me when I'm writing. The writers here know you can sit in one place and create a hole in that chair, seated 24 hours straight without even standing. If you really go, you are likely to lose track. And so you have to use another 2 days to know the concept that you're trying to build. So thank you so much. Eli Atumuza, in your absentia, is the biostatistician who came. Where is he? Oh, Eli Atumuza is here. Please stand up for recognition. Okay. So that's Eli who came in last minute to troubleshoot the just-in-time requirements for a biostatistician, and is a PhD fellow at MAST. So slowly by slowly, let me introduce you to Dr. Lynn Matthews, who has been my research mentor since 2016, who is a reproductive health scientist and has mentored me through the different fellowships and through the K43 pilot until now. She's very, very hands-on. If you met her, you will fall in love with her. I'm very sure she will be happy to be here, but she couldn't make it. Dr. Van Gien is a health economist and assistant professor at the University of Alabama at Birmingham. She's not here, but also there is Dr. Alan Tita, who graciously allowed to help us on our grant as a maternal fetal medicine consultant, also based at UAB. Last but not least, Dr. Mark Seidner. You have talked about me, but you allow me to talk about you for 2 minutes. Dr. Mark Seidner, I learned about him when I was working as a research assistant in Dr. Judy Hahn's study. This is Dr. Judy Hahn. You're welcome. So I was puzzled and wondering why women were dying of postpartum hemorrhage. And of course, with a story of my auntie, Mama, dying suddenly and there was no explanation. One time I came up with a concept and I walked in his office. And I don't think he knew even what I was talking about. I was blah, 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 blabbing things. And you know, when I'm very nervous, I tend to stammer a bit. And so he looked at me in my face. I figured he didn't know what I was talking about. And so he says, he looks up and says, so what do you want me to help you with? I had not interfaced somebody who is very direct and wants you exactly to tell him what you need or what you want. So I said, I just want to do this research, but as part of my PhD, which I will be enrolling. So he says, first things first, I'm going to send you a bunch of literature you will need to read, and tomorrow come and talk to me about A, about B, about C, about D, about E, about F. And one of the things that he wanted me to do was to distinguish between designs of what I want to do. I had never had things like an equivalence trial, a non-inferiority trial, a superiority trial, then what trial? And then he sent me a bunch of 18 articles that I needed to read and come to see him the following day at 2 in less than 24 hours. I left his office, but I knew that he's a very, very, very smart clinician, and I would do what it takes to make sure I prove that I can do this. I went home, grabbed a chair, and I sat on that chair for 24 hours. Summarized everything, summarized all the articles that he had given me. And I hope when I returned the following day, I returned like a champ. I was walking like I was already a professor back to his small one-roomed office. And he looked at me like, have you done the work? I said, absolutely. So he said, let's start. And then, and he said, we are ready to go. You don't know what you did for me that day. You set my career without prejudice, without asking for anything, I was worried you'd ask me for pay, which I did not have. I was worried you'd ask me for what, because before I came to your office, I was coming from the office of a colleague in the Department of Community Health, and I had had this over my shoulder for a long time, and I wanted him to help me with the epidemiological aspect, because I had the pharmacology supervisor as a primary supervisor, but I was lacking an epidemiologist. So I walked into the community health, and this guy told me, and I quote, I don't want to be used as a doormat. Go and find somebody else. As I walked out of that office, I think that's when your name came in. I'm like, I know he will not tell me this. Even if he refuses, I will know I have tried. And nobody could just walk in Dr. Mark's office just like that, because I had never even been there. But that day changed my life. Thank you so much, Mark. And I think he has this humor and humility of even sending you more opportunities. Please apply for, I know you can. Please apply for this. And then I'm like, you know what? I have just had a baby. Maybe in my heart, I'm like, I have just had a baby. This is enough. I've just done this. I have arrived. I got my PhD that I needed. It's like, no. I know you can do this. I know. You remember when you found me at the reproductive health conference and you twisted my arm to write for that D43? And that is where I ended up. In 24 hours, I'd already submitted a proposal and it was funded, and I ended up in Professor Boa's D43 and later on in a K43, and here we are. Thank you for believing in me, even when I don't usually feel like I do. But I think if I did not have you, and I still insist, if Dr. Mark Seidner was not there to push me, and for me to feel like I need to do something, not to waste his time, and for him to feel like he wasted his time, I don't think we'd be here. Please clap for Dr. Mark. Right. Professor Mbarara, Professor Mbarara gave me my first opportunity as a research coordinator on her grant, which was called Wise Pill. And I was getting money, fair enough. But one time, I felt like I was not doing enough. And she gave me an opportunity. She would talk to me, no, if you know there is any data which you can write, I will support you. You know how she's very easy, very calm, with that humility, there is no push, there is no, rush, but it's just one word which you need to conceptualize and tease out and work out. And so on one of her many visits, she said, no, if you having any data, if you synthesize it, I will be happy to help you and you publish. I'm like, hey, publish. Okay, let's go. I go through her data and pick out the concept of social support engagement to improve care utilization in our setting. And I was excited because it was like I had seen the magic pill that will work for our community here. Because we are a community and it works within a community. And so I called him on one of the calls. I'm like, this is what I want to write. He's like, go ahead. And then we published the first paper in 2017. And I have never looked back. Thank you, Jessica, for entrusting and believing in me. And so she introduced me she birthed my career in intervention development, both of them showed me where the money comes from. And I got to learn things like NIH, which I didn't know what they meant. I got to learn other things that are the reason why we are here today. So I will quickly have a demonstration for the app in 2 minutes, and then we'll wrap this up. Thank you so much for listening to me, and I am very honored and very happy to have you all here. I have a brother of mine there, I have my 2 parents there. They had already introduced you. Scholars, thank you for coming. My fellow colleagues, thank you for coming. And together we can run, together we can do something within our communities together. Thank you so much.
Thank you, Dr. Esther. As you leave the podium, the DJ is going to play something. Starting now, it's your...
Katwesije ngwe sande huireje mbwenu twagaruka erizo bantu zaganira hakora baje omubire bukuzara ebishako biri kutandika bayishanga mu kintu kitari kya burijo koro kuba yitebekanise noja kubishemererwa oyanguhirwe ugume n'obusinge hamwe n'ababare niwe genda hirwariro eriyo yitebekanisize kuzariramu bachebere bamanye mbera yawe n'umwana omuzarisa naija kuguma hihi ubwo ari. We hope you had a good week. Here we are back. Today we are going to talk about native medicine in pregnancy. Native medicine means herbal medicine. During pregnancy, especially the first 3 months, the vital structures of your baby are being formed. So this process needs no interference. Use of herbal medicine is common among pregnant women to treat nausea, vomiting, reduce the risks of preeclampsia.
We don't want to preempt the next presentation. That's a sample English and Runyankore version of the kind of messages that are creating impact amidst our clients. Angela, go ahead.
Oh, thank you so much, Dr. Godfrey. The wind below the wings of the flying lady. Yes. Are we there? It's time for lunch. You're not happy. Okay, let me continue. Ladies and gentlemen, everything Dr. Esther said, we can forget everything, but let's not forget that she's here to save mothers. But most importantly, This is going to help mothers have garbage out. They have a lot of garbage and assumptions and superstitions while pregnant. There was a pregnant lady I met in Rebicona. She was so heavy. I told her, where are you doing your antenatal? She said at Municipal. I told her, why don't you come to Mbarara? She said, there they just cut. They don't even ask. They're like, next, they cut. They remove the baby. Next, cut, they remove. They don't even consult you. They just cut. So with this, I think the mothers will know why they are getting C-sections. They will have the right information, and they should not have garbage in, garbage out. I hear when you produce at mass, you only produce boys because the doctors there are men. Even I. There's a lot. There's a lot. We need to work a lot. You need social scientists there. Allow me to welcome and recognize also other people with us. I don't know if they're still there. We have Camtech Uganda, represented by Miss Nuriat Nambogo. Are you still there? Yes, I congratulate her for finishing the 9th hackathon. And ladies and gentlemen, for those of you who are not there, they innovated. The first runners-up, the best innovator innovated a brother tests for cancer. Because mothers don't like to undress of late, the doctors are very young, and she says, remove your clothes. So the mothers are just given a test. Then the other was an innovation about testing for fruits in the market. They're sprayed with chemicals and everything. So someone innovated that. Thank you so much, Nuriat, for always fronting. Send our message to Dr. Data for this. In the house, we do have Professor Leju, Associate Professor Leju, the Dean Faculty of Science. Thank you for giving us science teachers. Ladies and gentlemen, we do have people from the pharmacy department, pharmacology. Mr. Ororo, are you there? Yes, we do have Dr. to be Amanya Martin. You stand up, Munange, Professor is here. Yes, we have Dr. Chans. Oh, you guys look alike, you confuse me. Okay, yes, we have, this is the only person. Let me first tell you, he's called Kipto Joshua. Joshua? Is Joshua around? He stepped out. Yes, Joshua is the only Kipto who does not run. I can also run faster than him. All Kips run. We have Daniel. Danny, please stand up for recognition. So these are the brains under pharmacology and pharmacognosy. Thank you for being with us. I was challenged. This is ICT, and allow me to welcome and recognize iStreams. iStreams. Here we have Mr. Amos Baliashaba. We have Mr. Sam Mugisha, Mr. Galiwango, Marvin Taremwa. The reason as to why we're recognizing these people, they may have stepped out. They are the founders of ICT Solutions that developed the prototype of this app. They could have done this in the US, but they chose to do it here and get real-time solutions. Ladies and gentlemen, let's put our hands together for the ICT team that was behind this innovation. Even the little ones know that sitting for long is not healthy. People wearing ties, it's cold outside. Can we rise for a booster and we understand this? It's not going to take long, ladies and gentlemen. We are going to have a small booster. Just stand up. Thank you. Now take your seats. Thank you. Thank you. Let's have the demo, please.
The app demo is going to be very quick and brief. Semitego James, you're welcome to the podium. Please come and share with us very quickly what Support Mom stands for. And I think this is the reason as to why many people are here today. And
ICT people don't talk for long, so he has only 7 slides.
As he starts, I just wanted to share one message from Dr. Ester. She missed this out. And this goes to Mark Sidner. And Judy Han. One time, Esther came home and she asked me, we are here as research assistants. Some people, our bosses are research coordinators. They really guide us and they are actually our bosses and they want us to do this work day in, day out. But I've been wondering if these people have a lot of money to employ all of us, where is their money coming from? And she says, that is the place I want to be. She was actually fed up of being a coordinator, but she wanted to be a PI. And today, Esther is a project director. The sky is her limit. Thank you.
Okay, thank you, Doctor. I'll be taking you through how the Support Moms application works. Basically, the application has core functionalities, which are listed below. I'll be taking you through. And it's being used by VHTs that Dr. Esther had highlighted in her presentations, study clinicians, authorized study staff. We do user enrollment and authentications. We enroll participants. We schedule them to receive the calls and messages. And we do logging of these messages and voice calls. Then lastly, also do data reporting and extraction. I'll be taking you through how all these are done shortly. I won't go through everything. We do enrollment, and it's done at the dashboard level for all the users we have, depending on their roles they have on the application. So the study clinicians and the study staff and VHTs all have access to the mobile application. It's only the study staff that are limited, that have access to the dashboard. So once they're enrolled, they will access the platform. So the first graphic on the extreme end, the other side, is how they access the dashboard, and the mobile application is this here, where they also provide the details that they will have assigned to them. Then we shall enroll next the participant. Then we provide their schedule parameters, which will enable them receive the calls. So depending on the choice of communication, whether they want to receive both the voice and SMS, then also their preferred language. Then next we shall capture the preferred time of call, which when they are not very busy, then the days they would love to receive these messages. And the other important parameter as well, their contact, which we send these messages. As Dr. highlighted in her presentation, we capture different contacts for the social supporters, the partners, and the VHTs, so that they channel out the reminders to support the mother. So once all these are done, they are synced on the dashboard, and the scheduling happens, and they will receive these calls according to the parameters that have been set. And lastly, this is how a message looks like on the phone. When it is received, we shall play a demo like they had already done, so I don't have to do most of these. Thank you.
Yes, thank you, but the demo continues. So the IT person is going to get back to his seat. Amongst us, some of you are participants who have consented to receive these messages. The messages were planned to be received at a particular time of your choice. The message is automated, it is interactive, and we want to find out if any of you will receive a 032 call. Right now, if you get a call, please raise up your hand. And then we see what the mother will go through in real life. Your phones might be coming. Remember, the mother chooses the time of the day to receive the phone. It is embedded in the system, and when that time reaches,
Yeah, Dr. Godfrey, if you allow me, this gentleman has presented, you just gave us his name. I kindly request he introduces himself for further, not business, but reference.
Yes.
Okay, thank you. Semitego James, the application developer for Support Moms. Thank you.
And you work with?
I work with Support Moms.
The IT company that you work for?
It's Ucash Technologies.
Ucash Technologies. We are in partnership with Africa is Talking.
That advert will be taxed. Let's just continue.
Local solution. So I don't know if you're okay with the setup. We're waiting for the caller.
Dr. Godfrey, you're standing between lunch and us. It's not me.
I know.
Yes.
Yes? Maybe someone is receiving the call and is not.
You could do the other and they do it at the end. We save time.
If you receive a call, just put up your hand from 032.
People are rejecting the phone calls because they're good people in class. Don't receive calls in class.
No, it's okay, Angela.
Yeah.
Let's give it time.
Just pick any call that comes, even if they are demanding some money, just pick.
Must be 032. Because the presenter was, as we wait for the calls, we're preparing for a very quick discussion between key stakeholders. I'm going to ask Dr. Sebutinde to move forward and take a seat on that chair. I will also ask Dr. Byamjisha Sadiq, the DHO of Mitoma, to follow. And I will ask Dr. Dan Morokora to also follow. And we shall have a very quick discussion.
Which is like 5 minutes?
There's a call here.
It had better not be.
Hello.
You are welcome to Support Moms project, which is implemented by Mbarara University of Science and Technology in Uganda. Support Moms is a patient-centered mobile technology innovation aimed at improving maternal health in Uganda. We shall provide you with monthly pregnancy-related SMS and/or audio messages to offer you essential knowledge about antenatal care services, your health, and that of your growing baby. We shall also provide you with upcoming clinic visit reminders to your phone. You may also receive social support from trained people from their social networks. Messages will be about topics related to pregnancy, labor, delivery.
I think you listen to the kind of message, and this belongs to the DHO. The DHO is a pregnant mother at 10 weeks. So that is how it will go, but we didn't reach the end. It would give instructions, continue attending antenatal. If you want to listen again, press 1. If you want to pause, you're not comfortable to receive the top, pause, you can, then at the end of it all, you can hang up and wait for the next week for another message. Very briefly, we are going to ask these people questions. Dr. Dan Morokora, what is the role of health workforce in Uganda to make sure that mothers are saved? 2 to 3 minutes, and then we move on to the next person. Thank you.
Yeah, thank you, Chair, and I have the honor to speak to that point. There's no way we can implement maternal health interventions without a key pillar of an effective health workforce. And of course, as you've seen, the data has spoken. An informed population is an empowered population. But when you get this empowered population all coming into the health facility to a health workforce that is incompetent, brings challenges in delivery of quality of care. We know, for example, in the recent MPDSR reporting, that we noted a significant proportion of perinatal deaths and maternal deaths occurring because of either misdiagnosis or wrong interventions. And therefore, we need to have a competent health workforce that is aligned to delivery of respectful care. And I think when a woman comes and she's empowered with this information, her expectations are very high. And therefore, the health provider will be put to order to provide the demanded high quality service. I've had the opportunity both at regional level and lower levels through our Babies and Mothers Alive program, but also the national lens, because we co-chair the MPDSR with Dr. Mugahi. We see these things every day. And there is a tendency for the health worker to pass the blame to the client because they say they came late, there was no partner support. All these issues come in every day in our discussions. And therefore, Support Moms is going, in my view, to provide this empowered population with the right information. But a health worker must know better, because you're going to have an empowered population, but the health workforce also must be up to speed in delivering the right guidance, because not everything can be fully explained at all times. Technology is very useful, and we believe that the health workforce will be able to use this information. At an appropriate time, Chair and probably the university would be happy to share with you some of the work we've done on Mama Rescue in the Babies and Mothers Alive Foundation in Rakai, where we've also used a similar technology using USSD and SMS short codes and the interactive voice response to coordinate transportation for pregnant women whom we enroll on their 4th visit in Antenatal. And this solution, to me, working with the health workers, is able to give us the full range of the MCH interventions that would be able to improve clinical outcomes. So I thank you very much for this opportunity and happy to continue to contribute. Thank you.
Thank you, Dr. Dan Morokora. Just pass the microphone to your neighbor. Dr. Sadiq, the DHO Mitoma, what are the roles of village health teams in the health sector in Uganda? 2 minutes. Thank you.
Thank you very much, Dr. Mugayi. My name is Dr. Byamuksha, as you have said, the DHO Mitoma. I first of all want to take this opportunity to thank the team, the brains that came together to come up with such important project that is going to help our mothers in the villages. Muri kubaterera omungaro. Mujenyi, you have a gift in your house with such a brain to come up with this project. You thank God for that. Now, you have asked me a very important question about the core team that we have in our villages, the VHTs. I want to request all the VHTs who are present here today to stand up. The VHTs, kindly let us give a good clap to these people. Thank you very much. These are people whom we rely on as health sector. They are our health center one in the villages. And their roles is voluntary. Voluntary, how many people can volunteer? You have heard the good words from the project director. How she went to somebody to say, please assist me, and somebody was unable to do that. And frankly said, I can't do a dormant what? These people do the voluntary work. And their roles mainly is to mobilize our communities for health service delivery. And in doing this, they almost participate in every activity that takes place in the health sector. They are the custodians of the map of the villages. I don't know how many of us have the maps for the areas where they work from, but these people have the maps for their villages. And whatever we do, including most campaigns that we go for, routine services, these people are key in doing that. They have gone ahead even to participate in the work which we would be doing as health workers. They treat some of the common diseases. In districts where we have ICCM, these people are equipped with test kits. Test and also do what? Treat. What haven't they done? Including referrals. Support those ones who are taking medication, especially TB and others in the community. I want to conclude by saying these people must be thought about. Every time I get a chance to talk, I say VHTs should be thought about because they do the important role in our communities. You cannot keep volunteering, okay? Forever. Thank you very much.
Thank you. Pass the microphone. Dr. Seutinde, very briefly, focusing on translating evidence into practice. Dr. Mgai is very eager to utilize these research findings from the universities and other institutions into practice, reducing.
Yeah, thank you. Thank you very much, Dr. Mjenyi. And ladies and gentlemen, for every report, for every articles, for every publications that you have made, at the end of that paper, you make recommendations. And you hope that somebody will read and understand what you recommend. But you want to pick these recommendations and put them in context and get the evidence you have given as academia to improve and to be translated into practice and improve the practice. Two things must happen: the context and the content. The academia, you have done very well. Dr. Mjenyi, Dr. Esther, this is excellent for this audience. But the innovation in here is focusing at the woman in the village of Katete, in the village where you come from. The good thing, we are making it audio. They may be not able to read, but they will listen. What about the systems within which they live and operate? This science must be translated and reach them. So the context then has to be, Dr. Mugai, at the policy level, you guide and direct the content and the context. We want to see policies speaking to this. That will be content, that will be context. We want to see guidelines. We want to see that the evidence created here will now trickle down into the standards of care, focusing on this woman, focusing on this family, focusing on this man who is responsible for the pregnancy. What are we saying to this man? The 25 areas that have been selected, we are talking about male involvement. And the content there is sort of, we are requesting the woman to encourage. Please talk to your husband, entice them to give you transport, speak to them well. We want to see the other way. It should be the other way around. What are we as service providers telling the man? Because he's responsible. Recently, I was reviewing a paper for MPH, and they're talking about intimate violence. And they asked a fundamental question: why do you allow to be battered? And the response in this study was, because he's the man. Now, that man must be targeted, even at the policy level, at the implementation level. Academia has done their work, but we have also to involve the implementers to be able to get the content and the context of the recommendations made therein and implement. So we want to see local governments, we want to see DHTs understand what is at stake and do what they're supposed to do, and an environment to enable them to implement these recommendations, these guidelines made. Dr. Dan has talked about a competent health worker. This is where we are going to implement and apply the things that we have discovered, the evidence that we have discovered in science, but now practice what the evidence is. And it takes time, it takes commitment. I know you are pushing me that time is gone, but this is very important. Dr. Mugai, capacity building for these health workers, that is contextualized with the evidence and the science. That now the direction we are taking is to empower the woman, but empower the man. What are we saying in that context for the health worker? What tool do we have in place? Dr. Esther, the tool that you told us about, is it going to be implemented? Is it going to be eventually taken to the facility level for implementation? Is it applicable in a health center 3 setting with the team there? Or you remember there's a facility and there's a community. We must strengthen the bridge between these two places. The home of the man who made the woman pregnant and their connection to the health facility. When we strengthen that bridge, when we do these things, then we will be able to translate this evidence that we have generated as academia into practice. And now our decision making and practice on a day-to-day basis will be evidence-based, not necessarily recommendations that have been made for a reader of an article, a reader of a paper. The end users of these innovations do not read our articles. They don't even know. They don't want to know how many papers we have published. They want to see practice change. How do we make the midwife speak better? How do we make the midwife love the mother better? How do we make the husband take more responsibility? That is translation of evidence into practice. I thank you.
Put your hands together for this team. We thank you for this function. You're welcome back to your seats. You raised a few points for clarification. I have hurried you up. Otherwise, I was directed to remove you from the program, which was dangerous. So one of the things that has caught my attention in this, the commissioner signaled me to tell Dr. Esther that you are actually enrolling very few mothers, only 800. My response was that this is research. We are generating evidence to be very crystal clear that what we are going to tell you is possible and can roll out into the whole country. That's one. Two, the DHO mentioned that the clinicians need to be brought on board. We couldn't give all the information in this half day. Midwives from the health facilities who are here, stand up for recognition. The midwives, actually, these midwives are the ones who are going to eat some of the money in this grant, because for the next 5 years, they will be involved in enrolling the mothers on the app. The app will be run by the mothers, the midwives at the health facility level. They will be the ones that will be giving them the appointment dates. And for us, we shall not follow that in detail, but we shall come out at the end to assess the outcomes. I think I have briefly answered that. We are preparing for the real function of the day. What USSD, what is SMS codes do you use? Do you pay UCC fees annually? These are some of the technical questions. And people are thinking this money is going to be eaten by Mujenyi and Esther. So I'm going to ask Semitego to answer that. Thank you.
USSD, basically we don't use USSD. We only send text messages for text messages and voice calls. So for USSD, we are not using it. USSD is unstructured text, basically. Yeah.
So we are engaging a lot of service providers who are going to be relaying these messages to the end user. And I think that is technical for behind the scenes, which we didn't want to engage into today. Angela, go ahead. Thank you. There's still some.
Thank you so much. Let me invite the following persons to take up the stage. I would like to invite the keynote speaker. Please come to the stage. I would like to invite the DHOs in the house. Yes, I would like to invite, oh, sorry, on the we're going to unveil this thing. But you can stand next to me, we are smart. The next person is the Vice Chancellor, Professor Celestine Oboa. And then I'll invite Agaba, Professor Agaba. And before even the day ends, Professor Kazoba is tasked to get Mark a name. So Professor Mark, please take the stage. Dr. Mujenyi, please take the stage. I'm coming to organize everyone there. And then I need one VHT and one midwife. And the smart one stood up and came and stood with the VIPs. Thank you so much. Yes, if Kwetega was a person, that is the thing. Yes, thank you so much. You are?
Midwife.
Midwife, thank you. If Kwetega was a person. I need a VHT.
Angela, as the VHT comes,
Yes.
Professor Obua says he has recognized there are pregnant women in the house. At least one pregnant person should join
Not
us.
this one that has just started, the other one that is saying hallelujah, hallelujah. Najuma Josephine, you voted. Please bring me Josephine Najuma here. I don't know whether I'm surviving her tonight. Okay, let's stand in between and then I will take the instructions. Let's go behind we pass here. Now we are testing you again. That's how, yeah, the gentlemen are fit. They don't use my stairs. Come forward, yes. Beside, so let's come in where others can be a background. We don't all have to be in front. Thank you. We get them down.
I think Angela down is fine because the videographer people will relay the pictures, the screens. Crew, kindly help us to take this down.
Another idea, we take them back.
No, it's okay.
And then
the videographer
the cutters
will.
are down. The knife is coming, it's electronic, so it's digital. You just come here, Professor. Has the pregnant lady gone into labor or something? She's shy. And I didn't spoil the pictures I went out. We have to launch this. Esther. Okay. In 3, 2, 1, 0. And the midwives knew what to do. So after that, what have we seen? What is there? Thank you.
Wow, thank you.
That is not it. The keynote speaker. I will have more pens. Please put a signature. Oh, dig it. Oh, yeah, you can. You can even put a sum of figure for the MC. Yeah. Messages. We've not yet even launched. We need a mother to sign. Guys, if Najuma is not here, we have all dead. Those bringing her and me announcing her. Please sign, please sign. The photographers are doing their work. Thank you. So we can't cut the next thing before Josephine gets here. So Dr. Esther has gone for Josephine. Thank you, Professor Kazova. Thank you, Jessica. Thank you. Thank you so much.
There is enough space on this board for everyone to sign.
Professor Lele, please come and put a signature on behalf of Mastrek.
After here, these boards will be put in the restaurant. As you eat your lunch, you will add your signature
Stevens,
there.
Please come and represent MGH and put a signature. No, we are not yet done, Professor.
We're not yet done, Prof.
Dr. Stevens, we're just waiting for your signature. Mastrek, Gladys Nakalema, you can represent REC. So, a signature, and then Josephine is here with Esther. Thank you so much, Dr. Esther. Yes, VIPs. No, now Josephine is not signing. She's coming here to launch this. Professor? Cameraman, please get the right angle of Josephine. Yes, thank you so much. Well, the husband will kill me, leave me alone. Thank you, Gladys. Thank you, Josephine. Yes, thank you. Okay, now we are cutting the next one. Here we go. Let's hold this. So this one, with the, okay, just cut and find out what's in there. Okay? Okay, let's support her. Okay, let's all touch with Josephine.
Thank you.
Yes, cut the other. Yes. I'm told pregnant women are not supposed to cut. Okay, yeah, Josephine. Yes. And she's having the same hairstyle. Okay, let's have a photo there. Remove the scissor. Don't cut our baby before the baby is born. Okay, Josephine. I wonder next time if they are launching for gynecologists, what they will show us there. Okay, thank you so much. We're going to have the closing remarks by the Deputy Vice Chancellor.
Thank you. Like I mentioned, this for signature is going to be taken to the restaurant. If you feel you are part of this function, you will have to put your signature on the front face. Thank you.
Just closing remarks. You know, sometimes it's very, very difficult to make a closing remarks when you are in the audience with your senior supervisor, in this particular case, Professor Obua. But for today, let me make a closing remark on behalf of the university. Just listening to the discussion that have been going on, I just picked two things. When Esther, you were trying to describe how you met Mark and what you discussed, and I don't want to go to that long story, it is well known to everybody. Mark, you know, the comments were very excellent, but this is what I picked out from the interaction you had. For us in academia, they used to say either you publish or you perish. But now the thinking nowadays has changed, and I'm referring to that interaction which you did. The thinking today is either you network or you perish, because I believe if you network, the publication becomes a subset of the network, and we need to thank you. So for that, Mark, from what you have done for Mbarara University and what you have done for Ester, this is the name that has come to my mind. Tumwebaze. Tumwebaze. So what does this one mean? Just I want to translate it for you. Let us thank him. Let us thank him. So we need to thank you for the great work you have done for Mbarara University and for the great work you have done to Ester. So to you colleagues who are seated in this room, as I conclude my first point, please go outside and network. Network, network. For Mbarara University of Science and Technology, for Uganda as a country, and for yourself as an individual. End of that first remark. Number two, from the discussion, I want to go into the science of maternal health. I want to go into maternal, but also for us who are from the accounting field, we have got what we call integrated accounting, or even social and environmental accounting. So when we are talking about the impact of all what you are doing within the community, for me as an accountant, I can translate them into numbers, and you and me know if you cannot put something on a number, sometimes it's very difficult to be done. So let me leave it at that. Number two, from the discussion this morning, and I was among the first people who came here, and this is what I've been listening. And I have listened, I have seen what the impact is doing in the community, the statistics were presented by Esther, what Jessica you mentioned, Mark, what you mentioned, even what the DHO were mentioning over here. This is what I've picked out. Big packages, big parcels come into small things. They come into small things. Just as an example, let me demonstrate this one. Have we ever seen a crane being transported on the roads in Uganda? The answer is no, but it comes in small parcels. Now, the journey which Mbarara University of Science and Technology, even when we look back in 1989, and I was sharing with the doctor here, by the Mbarara University of Science and Technology, though it started in October 1989, it should have started in 1988, but there were some challenges, some hiccups. So what am I trying to say? We are here simply because there was somebody who started this journey. There is somebody who started this journey, and this is what I'm trying to say. Colleagues, remember this. Big packages come in small parcels. So let us go outside there as colleagues from Mbarara University, as our partners and the rest of it, so that we can do what? Create, come with simple things, solutions, but I know it will create an impact in Mbarara University of Science and Technology. I end that. Now my final role on behalf of my senior colleague, Professor Celestino Obua, by the powers now, you can see, by the powers now entrusted to me, I now close this launch of this project. Enjoy your meal, and I thank you.
Yes, ladies and gentlemen, the only thing that is standing between us and the lunch is a group photo that's going to be done on the stage. Angela is doing the best. We are going to call people in groups. DJ, you better play the messages because I think they will appeal to the function than anything else. And I'll remove this. I will ask the commissioner to come and take the seat of your choice. I will ask the Vice Chancellor to come and take the seat. We shall also ask Dr. Ester. Dr. Ester, come and take a seat.
Godi, go and sit. This is not a joke. Yes, the Agaba and Tumwebaze? Yes, Tumwebaze and Agaba. Yes. Okay. DHOs, please let's join. Dr. Stevens, please come, and the deans. Now the first photo is for VHTs. Let's take the stage. VHTs, Tujet the smiles of the big guys are still there. I love the gender balance. You're going? VHTs, let's hurry. No adding a chair. We've already managed the frame. VHTs, use even the stage. Stage. Yeah, some of you, those of my height, you use the stage. My relatives, you use the stage. No one should go beyond here. Musa stage. Dr. Stephen is the last. Stage. Musa a stage. Yes. The lady at the end is smiling so well with her belly. Okay, let's look here at the camera. Camera 3, 2, the smile is support moms. Yes, thank you VHTs. The next, we are having, do I remember my relatives? Let's have obstetricians and midwives. The sitting team, you stay there. That's the punishment. The sitting team, you stay. Please, obstetricians and midwives, please, let's move. Yes, the seniors. Don't cover that lady, please, in whatever you do. Ladies, let's use the stage. Let's use the stage. Ladies and gentlemen, we're going to have lunch in alphabetical order. Angela goes first. Okay, come closer. Okay, are we ready? 3, 2, 1. Support moms. Mothers? Okay, thank you. Okay, let's go. The next, let's go. Let's go, let's go. Do you want me to invite you by name? No. Let's go. Must team. Let's go. Let's go for the photo, please. And those with the best. Okay. Psychiatry, rec, grants. Let's do the last. This is the, yes, thank you. Rec, thank you. MGH, thank you. This is the last one. Must teams, please. Let's go for the photo. Let's all come. This is the last photo. Yes. Don't leave here without a new number in your phone. Take a contact. Thank you. Use the stage. Yes, people of my height, you use the stage. Gladys is the last person. Kathy, don't push our mother. Celestine, get on the stage. Is this all? I need more people. Margaret, why aren't you guys here in this photo? Okay? 3, 2, the smiles, support, moms. And the last one, give me a wave. 1, 2, 3. Yay! See you in Harvard where? Yay! Professor Bua, you're running away from the photos. Bon appetit, ladies and gentlemen. Let's go for lunch. Housekeeping.
Bankubanze nane nubuka katono nnyo kunzita bwe yantunulira nga bankuba simuyita muliye nalumwa bwe negaganula nze nembalopa jali ababa nkunyakunya kutenya kikowe ngulukuba lumuye yali abawunzise kati nawumbula kuba nakiyiga nti ntalo musufu katinkanya kulopa eryatawangulwa mukama natamibwa era ndi mulinda ndikulinda era ndikulinda wateekanga tebiri bulungi era ndikulinda sirita mayengo sirita muyaga watenga binkuba wakati mumpewo mumusana pereketya wadenga binkuba wadenga ebiro birabika bigenze manyi kabire bigambo ebiva mu banyomi tebiri kundesanze nsabye ne basaba era tebikoze wate tebikoze amaluwe empologoma awamu